Welcome to Most Disturbing Psychological Disorders to Fall Asleep To. Fregoli delusion. Now imagine a reality in which everyone you encounter, friends, strangers, colleagues, feels oddly familiar, as though a single person is disguised and pursuing you everywhere you go. This unsettling phenomenon is known as Fregoli delusion, a rare and puzzling condition that turns the most ordinary interactions into a surreal and often terrifying experience. Those who suffer from this disorder believe that a particular individual, usually someone they know or once knew, has the ability to disguise themselves as multiple other people. Each new face they see is not actually a different person, but rather the same individual in another form, stalking them through a maze of shifting identities. The delusion takes its name from Leopoldo Fregoli, an early 20th century Italian actor renowned for his rapid costume changes and uncanny ability to transform into multiple characters on stage. In a similar vein, individuals with Fregoli delusion see the world around them as a stage upon which one actor continuously dons different disguises. A stranger at the supermarket, a pedestrian on the street, or a new neighbor all become suspect. To the affected individual, these different people are just the same person, cleverly disguised and intent on following or harming them. Fregoli delusion is classified as a delusional misidentification syndrome, much like Capgras delusion. However, while Capgras involves the belief that a loved one has been replaced by an imposter, Fregoli delusion flips the scenario, making every new face seem like a singular, persistent pursuer. In both cases, the brain's ability to correctly identify and emotionally relate to others has become profoundly disrupted, creating a fractured sense of reality. Neurologically, Fregoli delusion may arise from damage or dysfunction in areas of the brain involved in facial recognition and memory, such as the fusiform gyrus and the temporal lobes. These regions normally work together to distinguish one person from another and to assign appropriate emotional significance. When this system falters, whether due to a head injury, stroke, or psychiatric condition, the brain struggles to make proper distinctions. This confusion can lead to the belief that multiple individuals are actually one person in disguise. The emotional underpinnings of Fregoli delusion often add another layer of complexity. The individual's sense of being pursued, watched, or targeted can stem from underlying paranoia or a heightened state of anxiety. The delusion might also connect to unresolved emotional ties, such as a former relationship, an estranged family member, or a significant personal conflict. The person fixates on the idea that this familiar figure has not only returned, but has taken on a multitude of forms to haunt their daily life. As with other delusional conditions, Fregoli delusion is frequently associated with psychiatric disorders like schizophrenia, bipolar disorder, or severe depression with psychotic features. In these cases, the delusion becomes part of a broader tapestry of distorted thinking, making it even more difficult to treat. Neurological conditions such as dementia or traumatic brain injury can also contribute to the development of Fregoli delusion, particularly when the brain's ability to process faces and social cues is impaired. Treatment for Fregoli delusion typically involves a combination of approaches. Antipsychotic medications can help reduce the intensity of the delusional beliefs, while psychotherapy, particularly cognitive behavioral therapy, CBT, may help the individual challenge and reframe their thoughts. However, progress can be slow, and a strong support network is often essential. Loved ones and caregivers must navigate the challenging terrain of reassuring the affected individual without validating the delusion, all while maintaining trust and patience. Fregoli delusion, like other misidentification syndromes, forces us to confront how deeply our sense of self and reality is tied to the way we perceive others. When that perception breaks down, the social fabric we rely on can unravel, leaving us isolated and suspicious. For those who experience this rare disorder, each new face becomes a reminder of a world turned strange, where familiarity is not comforting, but rather a source of fear and confusion. Cotard's syndrome. Imagine waking up one day convinced that your body no longer functions, that you've ceased to exist as a living being. To those who experience Cotard's syndrome, sometimes called walking corpse syndrome, this isn't just a fleeting delusion. It becomes their lived reality. Individuals with this rare and unsettling condition believe that they are dead, missing vital organs, or even devoid of blood. In some cases, they may insist that they're merely a corpse walking the earth, detached from life entirely. First described in the late 19th century by French neurologist Jules Cotard, this disorder is classified as a neuropsychiatric condition and often occurs in conjunction with severe depression, schizophrenia, or brain injury. It goes beyond simple feelings of disconnection or sadness. It manifests as a deeply entrenched belief in one's own non-existence. For example, a person with Cotard's might refuse to eat or bathe because they feel it's pointless. After all, a dead person doesn't need food or hygiene. This leads to further physical decline, reinforcing their delusional state and making the condition more challenging to treat. From a medical standpoint, Cotard's syndrome has been associated with damage or dysfunction in parts of the brain responsible for processing emotions and self-perception. Imaging studies have sometimes revealed abnormalities in the parietal lobe and other regions involved in bodily awareness. This disruption can create a profound sense of unreality, convincing the individual that they're no longer alive. It's as though the brain's wiring for understanding self and existence has been scrambled, leaving the person trapped in a surreal nightmare. The condition can also vary in intensity. Some individuals may believe they're partially dead, missing only a few organs or losing their soul, while others insist they've entirely ceased to exist. In one famous case, a man traveled to a cemetery to find his own grave, fully convinced he was dead and belonged there. These beliefs often persist despite overwhelming evidence to the contrary, making the syndrome both perplexing and heartbreaking. Treatment for Cotard's syndrome is complex and often involves a combination of approaches. Antidepressants and antipsychotic medications can help address underlying mood disorders or psychotic symptoms. In some severe cases, electroconvulsive therapy, ECT, has shown promise, particularly when other treatments have failed. Psychotherapy may also be useful, though it can be challenging because the individual's delusions are so deeply rooted. The goal is not only to alleviate the sense of being dead, but also to address the broader psychiatric and neurological issues that contribute to the condition. For caregivers and loved ones, the experience of watching someone live through Cotard's syndrome can be profoundly distressing. The individual's firm conviction in their non-existence often leads to withdrawal, self-neglect, and a refusal of help. Patience, compassion, and professional intervention are crucial in helping the person regain a sense of reality and connection to the world. In the broader scope of human experience, Cotard's syndrome serves as a stark reminder of how fragile our sense of self can be. It highlights the intricate ways in which our brains construct reality, and how that reality can unravel under certain conditions. While it remains a rare and poorly understood disorder, each case deepens our understanding of the complex interplay between brain function, mental health, and the profound mystery of existence. Capgras delusion. Imagine looking at a loved one, someone you've known your entire life, and feeling an overwhelming certainty that they've been replaced by an imposter. The face, voice, and mannerisms seem identical, but to you, it's not them. This is the essence of Capgras delusion, a rare and puzzling condition in which a person believes that someone close to them, often a spouse, family member, or friend, has been substituted by an exact duplicate. The delusion, first identified by French psychiatrist Joseph Capgras in the 1920s, is considered a type of delusional misidentification syndrome. Unlike disorders that involve hallucinations or imaginary people, Capgras delusion centers on a very real individual whom the affected person no longer recognizes as genuine. To them, it's as if a stranger is wearing their loved one's skin. This belief can extend beyond people. Some individuals with Capgras delusion think that familiar places, pets, or even objects have been swapped out for replicas. A woman may claim her home is an identical, fake house, or that her pet dog has been replaced by a look-alike. In other words, the condition challenges not only interpersonal relationships but also a person's entire perception of their environment. The underlying cause of Capgras delusion is still not entirely understood, but research points to a disconnect in the brain's recognition system. Typically, when you see someone you know, two neural processes work in harmony: facial recognition and the emotional connection you feel toward that person. In Capgras delusion, these two processes become uncoupled. The individual can intellectually identify the person's appearance, but the emotional response is absent or disrupted. This disconnect leads them to rationalize the discrepancy by believing that the person must be an imposter. Capgras delusion often occurs alongside other psychiatric or neurological conditions, including schizophrenia, Alzheimer's disease, or brain injuries. It's not uncommon in individuals with dementia, where the brain's ability to process emotional and contextual information has been compromised. In some cases, traumatic events or extreme stress may also trigger the delusion, particularly if the person is already vulnerable due to underlying mental health conditions. Living with Capgras delusion can be profoundly isolating. Those affected may avoid or even lash out at the people they once trusted, convinced they're dealing with strangers in disguise. Family members and caregivers, in turn, struggle to understand the sudden change in behavior and the distressing accusations. It's a disorder that not only strains personal relationships, but also challenges the core of what it means to know and connect with others. Treatment for Capgras delusion typically involves addressing the underlying condition. Antipsychotic medications, mood stabilizers, or cognitive therapies may help reduce the intensity of the delusion, but the process can be slow and requires patience from both the individual and their support network. In some cases, family members and caregivers must learn specialized communication techniques to reassure the affected person and maintain a sense of safety and stability. Capgras delusion also raises intriguing philosophical and psychological questions about how we form our understanding of identity and authenticity. If something as fundamental as recognizing a loved one can become untethered from reality, what does that say about the reliability of our own perceptions? And how do we navigate a world in which the people and places we know best can suddenly feel unfamiliar and strange. For those who experience it, Capgras delusion can be a surreal and terrifying condition, reshaping their world into one of suspicion and doubt. And for the rest of us, it's a poignant reminder of how deeply our sense of self and connection depends on the fragile harmony of the brain's emotional and cognitive systems. Alice in Wonderland syndrome. Picture looking into a mirror and watching your own reflection shrink to the size of a mouse, then stretch to the height of a tree, all in the blink of an eye. Imagine walking into your living room and feeling as though the furniture is floating far above you, or that your hands have suddenly grown large enough to engulf the objects you're holding. This is the surreal experience described by those with Alice in Wonderland syndrome, AIWS, a rare neurological condition named after Lewis Carroll's famous tale. In this syndrome, the world, or at least one's perception of it, becomes distorted in bizarre and often disorienting ways. Alice in Wonderland syndrome is characterized by perceptual changes that affect a person's sense of size, distance, and even time. These episodes can cause a person to feel as though their body is growing or shrinking, their environment is warping, or objects are shifting size or position. For example, a small table might suddenly appear enormous, or a hallway might seem unnervingly long and out of reach. These distortions aren't hallucinations in the traditional sense. The person knows something is off, but they cannot correct their perception in the moment. Although its name suggests whimsy, AIWS can be a deeply unsettling experience. Episodes tend to come on suddenly, often lasting only a few minutes, but their intensity and unpredictability can leave individuals feeling anxious, disoriented, and vulnerable. In children, who are more frequently affected, these episodes can be frightening and difficult to articulate. Adults who experience AIWS may find it disruptive, particularly if episodes occur in everyday situations such as driving or walking through a crowded space. The underlying causes of Alice in Wonderland syndrome are still not fully understood, but the condition has been linked to a range of neurological and medical factors. Migraine headaches, particularly those with aura, are a common trigger. People who experience migraines often report similar visual and spatial distortions before the onset of a headache. AIWS episodes have also been associated with epilepsy, brain tumors, head injuries, and certain infections, most famously Epstein-Barr virus. These triggers suggest that AIWS arises from temporary disruptions in the brain's visual and spatial processing networks, rather than from a psychological or psychiatric disorder. One theory is that AIWS episodes involve dysfunction in the temporoparietal junction, a region of the brain that integrates sensory information to create a cohesive sense of body and environment. When this integration goes awry, the brain's internal map of reality can shift, resulting in the bizarre and dreamlike distortions that define the syndrome. In other cases, changes in blood flow to specific areas of the brain, such as the occipital lobe, which processes visual information, may play a role. There is no definitive cure for Alice in Wonderland syndrome, but treatment often focuses on managing underlying conditions or triggers. For those whose episodes are linked to migraines, preventive medications or lifestyle changes may reduce the frequency and severity of distortions. In cases related to infection or inflammation, treating the primary cause can sometimes alleviate the symptoms. For some individuals, episodes diminish over time, particularly in children who seem to grow out of the condition as their nervous systems mature. Despite its rarity, Alice in Wonderland syndrome provides a fascinating window into how the brain constructs reality. The syndrome's peculiar distortions remind us that our perception of size, space, and time is not fixed, but rather a carefully orchestrated interpretation by the brain. When that interpretation shifts, even familiar surroundings can become unrecognizable, as though one has stepped into a storybook world where the rules of reality no longer apply. For those who experience it, AIWS is not simply a quirky oddity. It's a condition that underscores the delicate balance of perception and the mysterious workings of the human mind. Although the syndrome's name conjures images of fantasy and wonder, the lived experience often feels more like navigating a waking dream, an ephemeral, surreal journey that begins and ends in the blink of an eye. Ekbom syndrome, delusional parasitosis. Imagine the unshakable feeling that something is crawling beneath your skin, tiny creatures burrowing, biting, and multiplying. No matter how closely you look, no matter how many times you wash, the sensation doesn't disappear. For people suffering from Ekbom syndrome or delusional parasitosis, this experience is all too real. Despite a lack of physical evidence, they remain utterly convinced that their bodies are infested with parasites or insects, leading to significant distress, compulsive behaviors, and a profoundly altered sense of reality. Ekbom syndrome is a rare psychiatric disorder in which individuals develop a delusional belief that they are being invaded by living organisms, such as mites, lice, or worms. Unlike general itching or a mild sense of irritation, the sensations reported in Ekbom syndrome can be intense and overwhelming. People with the condition may spend hours examining their skin under magnification, repeatedly clean or disinfect their living spaces, and seek multiple medical opinions in a desperate attempt to rid themselves of the supposed infestation. In many cases, they present samples, tiny flecks of skin, fibers, or dust particles, as proof of their condition, although these evidences are not biological parasites. The syndrome was named after the Swedish neurologist Carl Axel Ekbom, who documented these delusional symptoms in the early 20th century. Though the disorder has likely existed for centuries, his detailed descriptions brought it to wider attention, establishing it as a recognized clinical entity. In many ways, Ekbom syndrome overlaps with other forms of delusional parasitosis and somatic delusions, which are false beliefs centered on bodily sensations. However, the intensely specific focus on parasites or insects distinguishes it from other somatic disorders. The exact cause of Ekbom syndrome remains unclear, though it is often associated with other psychiatric conditions such as schizophrenia, mood disorders, or severe anxiety. Certain neurological conditions, including brain injuries or neurodegenerative diseases, can also lead to delusional parasitosis. In some cases, substance use, such as prolonged amphetamine or cocaine abuse, has been linked to feelings of crawling or itching sensations, which may evolve into full-blown delusions of infestation. While the underlying mechanisms vary, the common thread is a disruption in how the brain processes sensory input and interprets physical sensations. Living with Ekbom syndrome can be incredibly isolating and frustrating, not only for the affected individuals, but also for their loved ones and caregivers. Convincing someone with Ekbom syndrome that there are no parasites involved is exceedingly difficult, as their delusion often feels unshakably real. They may reject medical explanations, distrust healthcare providers, and insist on extreme measures to rid themselves of the imagined infestation, such as excessive use of cleaning chemicals, harmful self-treatments, or even unnecessary surgeries. Treatment for Ekbom syndrome typically involves a combination of approaches. Antipsychotic medications can help reduce the intensity of the delusions, while psychotherapy, especially cognitive behavioral therapy, CBT, can guide individuals toward more accurate perceptions of their sensations. In many cases, treating an underlying psychiatric or neurological condition helps alleviate the delusional symptoms. However, progress can be slow, and building trust with the patient is a crucial step in the therapeutic process. The challenge lies not only in addressing the delusion itself, but also in providing support, reassurance, and a pathway to a more stable and comfortable life. Ekbom syndrome serves as a stark reminder of the brain's power to shape our reality. It demonstrates how deeply our perceptions can be influenced by underlying mental health conditions, and how even the most physical, tangible sensations can become distorted. For those who live with this condition, the road to recovery may be long, but it begins with compassion, understanding, and a commitment to addressing both the psychological and physical aspects of their experience. Diogenes syndrome. Diogenes syndrome is a condition that, despite its name, has little to do with the ancient Greek philosopher Diogenes of Sinope, who famously eschewed material possessions and lived a life of voluntary simplicity. Instead, this syndrome is characterized by extreme self-neglect, social withdrawal, and compulsive hoarding. People with Diogenes syndrome often live in conditions of severe squalor, surrounded by piles of clutter, garbage, or unused items, and show an apparent indifference to their own physical and emotional well-being. First identified in the medical literature in the mid-20th century, Diogenes syndrome typically affects elderly individuals, although it can occur at any age. It is not classified as a standalone psychiatric disorder, but is instead considered a cluster of symptoms that can arise from various underlying causes. Some people with Diogenes syndrome have a history of mental health issues such as depression, anxiety, or dementia, while others may develop the syndrome after experiencing significant life stressors such as the death of a spouse, financial hardship, or a sudden loss of social support. A hallmark feature of the syndrome is the accumulation of items that others might see as trash: newspapers, boxes, old clothing, and even food waste. This compulsive hoarding can lead to living environments that become hazardous, not just due to clutter, but also because of health risks like mold, pests, and fire hazards. In many cases, the individual shows little or no concern for these conditions, rejecting help or offers of assistance from family members, neighbors, or social services. Self-neglect in Diogenes syndrome extends beyond living conditions. Individuals often fail to maintain personal hygiene, neglect medical care, and ignore proper nutrition. They may wear the same clothes for weeks, avoid bathing, and refuse to seek help even when facing serious health problems. This lack of self-care can lead to further isolation, as social contacts diminish and friends or family become reluctant to visit. Understanding what drives Diogenes syndrome remains a challenge. Some researchers believe it is linked to underlying neurological changes, particularly in cases involving dementia or other forms of cognitive decline. In other instances, personality traits like extreme introversion, perfectionism, or a need for control may contribute. Depression, unresolved trauma, or a history of emotional neglect may also play a role, creating a cycle where the individual withdraws further and further from the outside world. Treating Diogenes syndrome is often difficult, as individuals frequently resist intervention. They may not perceive their situation as a problem, or may mistrust those who attempt to help. Successful treatment usually involves a multidisciplinary approach, including medical care to address physical health issues, psychiatric support to manage underlying mental health conditions, and social services to ensure a safe living environment. Gradual, compassionate intervention is often more effective than trying to force immediate change. Building trust and maintaining consistent communication are key steps in encouraging someone with Diogenes syndrome to accept assistance and begin to improve their quality of life. Though the syndrome can be overwhelming for caregivers and healthcare professionals, it is important to approach the condition with empathy rather than judgment. For many individuals, the behaviors associated with Diogenes syndrome are not a conscious choice, but a reflection of deeper psychological struggles. Recognizing this helps pave the way for more effective, compassionate care. Diogenes syndrome serves as a stark reminder of how intertwined mental health, physical well-being, and social connection truly are. It highlights the importance of understanding and addressing the underlying factors that drive self-neglect, and it calls attention to the need for supportive, non-judgmental approaches that can help individuals regain dignity, safety, and a sense of stability in their lives. Munchausen syndrome. Munchausen syndrome is a rare and complex mental health condition in which a person deliberately fabricates or exaggerates symptoms of illness, often to gain attention, sympathy, or medical care. Unlike cases of malingering, where individuals feign illness for a clear external benefit such as financial compensation, those with Munchausen syndrome are motivated by less tangible rewards: emotional validation, a sense of identity, or the psychological comfort that comes from being cared for. The condition often leads to a cycle of repeated hospital visits, unnecessary medical procedures, and mounting distrust between the patient and healthcare providers. Named after Baron Munchausen, an 18th-century German nobleman known for his exaggerated tales of adventure, Munchausen syndrome reflects the same idea of crafting elaborate, convincing stories, in this case, about one's health. People with the disorder may go to great lengths to maintain the illusion of illness. They might falsify test results, self-inflict injuries, ingest harmful substances, or tamper with medical equipment to convince doctors of their condition. These behaviors are not driven by a desire for monetary gain or social status, but rather by an overwhelming psychological need to assume the sick role. Munchausen syndrome can manifest in various ways. Some individuals repeatedly visit different hospitals, often in distant locations, to avoid detection by familiar medical staff, a behavior sometimes referred to as doctor shopping. Others may become deeply enmeshed in a single healthcare setting, establishing themselves as long-term patients and forming close, complex relationships with caregivers. In either case, the person's actions are rooted in an internal struggle rather than external coercion. The condition is often associated with other mental health issues, such as personality disorders, depression, or anxiety. Some theories suggest that childhood trauma, particularly experiences of neglect or abuse, can contribute to the development of Munchausen syndrome. In these cases, the individual may have learned early on that being sick or injured was the only way to receive attention or care. As adults, they may unconsciously replicate this dynamic, using illness as a means of fulfilling unmet emotional needs. Diagnosing Munchausen syndrome is challenging, as those affected are often highly skilled at presenting themselves as genuinely ill. Medical professionals must carefully assess inconsistencies in the patient's medical history, patterns of frequent hospitalizations, and the results of diagnostic tests that fail to align with reported symptoms. Even when the diagnosis is clear, addressing the underlying psychological issues is no simple task. Treatment for Munchausen syndrome typically involves psychotherapy, particularly cognitive behavioral therapy, CBT, to help the individual recognize and modify the patterns of behavior driving their actions. Establishing trust is crucial, as patients often resist psychiatric intervention, fearing that acknowledging the truth will strip them of the attention and care they seek. Over time, therapy can help uncover the emotional wounds underlying the disorder, allowing the person to develop healthier ways of coping with stress and seeking support. In the medical community, Munchausen syndrome serves as a reminder of the profound connection between psychological well-being and physical health. It challenges healthcare providers to approach patients not only with clinical precision, but also with compassion and understanding. While the disorder can be frustrating and difficult to manage, it underscores the importance of viewing each patient's experience within the broader context of their mental and emotional lives. Munchausen by proxy syndrome. Imagine a caregiver, often a parent, who repeatedly seeks medical attention for a child, describing alarming symptoms that prompt doctors to perform tests, prescribe treatments, or even consider surgeries. Yet over time, something doesn't add up. The child's test results come back normal, or the symptoms appear only when the caregiver is present. This is the unsettling dynamic at the heart of Munchausen by proxy syndrome, MBP, now more formally known as factitious disorder imposed on another. In this condition, an individual fabricates or induces medical issues in someone else, typically a child, to gain attention, sympathy, or a sense of validation from medical professionals and others. Unlike Munchausen syndrome, where the affected individual pretends to be ill themselves, Munchausen by proxy shifts the focus to a dependent, often a young child who is unable to advocate for themselves. The caregiver may go to great lengths to perpetuate the illusion of illness. They might exaggerate symptoms, alter test results, or administer substances that make the child appear sick. In the most extreme cases, they may cause physical harm to the child to produce symptoms that doctors will then try to diagnose and treat. All of this is done not for monetary gain or clear practical benefit, but to satisfy a psychological need for attention or control. The root causes of Munchausen by proxy are not fully understood, but many experts believe that underlying mental health conditions, such as personality disorders, unresolved trauma, or deeply ingrained patterns of manipulation, play a key role. Some individuals may have experienced neglect, abuse, or abandonment in their own childhoods, leading them to develop unhealthy ways of seeking care and validation. By creating a sick role for someone else, they indirectly place themselves at the center of the medical drama, earning praise for their devotion as a caregiver and forming close relationships with healthcare providers. The consequences for the child can be devastating. Beyond the immediate physical harm, unnecessary medications, invasive procedures, or untreated complications, there are long-term psychological effects. Many children subjected to Munchausen by proxy grow up feeling confused, betrayed, and mistrustful. Their sense of autonomy and bodily integrity is often severely compromised, leaving them vulnerable to future mental health challenges. Some even continue to believe they were genuinely ill, only to discover later in life that their ailments were fabricated. Detecting Munchausen by proxy is a complex and sensitive process. Medical professionals must be vigilant for patterns, frequent hospital visits without clear diagnoses, symptoms that worsen under the caregiver's watch, or medical histories that don't align with test results. Child protective services and law enforcement may become involved when suspicions arise, as the well-being and safety of the child are paramount. It often takes a multidisciplinary approach, including doctors, social workers, and psychologists, to confirm the diagnosis and intervene effectively. Once identified, treatment focuses on protecting the child and addressing the caregiver's underlying psychological issues. Therapy, particularly cognitive behavioral therapy, CBT, can help the caregiver recognize and change their behavior, though progress is often slow. In some cases, separation from the child may be necessary to ensure the child's safety while the caregiver undergoes treatment. The ultimate goal is not only to prevent further harm, but also to help the caregiver develop healthier ways of coping and connecting with others. Munchausen by proxy syndrome serves as a stark reminder of how complex and intertwined psychological health and caregiving can be. It challenges both the medical community and society at large to remain vigilant, empathetic, and committed to protecting the most vulnerable among us. While rare, the disorder highlights the profound impact that mental health can have not only on individuals, but also on those who depend on them. If you're enjoying this journey, don't forget to hit that subscribe button and join us for more intriguing explorations. It really helps us keep exploring and uploading more content like this for you. Body integrity, identity disorder, is a rare and controversial condition in which individuals feel an intense and persistent desire to remove or disable one or more of their healthy limbs or body parts. This desire isn't driven by aesthetic preferences or a response to physical trauma. It stems from a deep and enduring sense that the affected limb or body part simply does not belong to their true self. To those who experience BIID, the limb feels alien, foreign, or even intrusive, causing immense psychological distress that often lasts for years or decades. People with BIID frequently report that their feelings of disconnection began at an early age. They may have an overwhelming sensation that a certain limb, an arm, a leg, or even multiple limbs, should not be there. This is not a fleeting thought, rather it becomes a central and unshakable aspect of their self-image. Some individuals express a strong desire to live life as an amputee or as someone with a particular physical disability, believing that only through amputation or functional loss can they achieve the physical state that aligns with their internal identity. The condition's exact cause remains unknown, but research suggests that it may be linked to disruptions in the brain's body mapping systems. The parietal lobe, which plays a key role in integrating sensory and spatial information, may not fully incorporate the affected limb into the individual's sense of their physical self. This neurological mismatch can create the persistent feeling that the limb is extra or that it belongs to someone else. Although more research is needed, studies involving brain imaging and neural connectivity have begun to provide glimpses into how this disorder might arise. BIID is not classified as a body dysmorphic disorder, which typically involves excessive preoccupation with perceived physical flaws. Instead, BIID is rooted in the individual's identity, a mismatch between the physical body and the internal image of what the body should be. This distinction makes BIID fundamentally different from conditions like anorexia nervosa or typical body image disorders. Living with BIID can be deeply isolating. Many individuals keep their feelings hidden, fearing judgment, misunderstanding, or rejection. Those who do seek medical help often find that doctors and therapists are unfamiliar with the condition or hesitant to address it. This lack of awareness and support can exacerbate the distress, leaving sufferers feeling trapped and unable to find relief. In some cases, individuals with BID have taken drastic measures to remove or damage the offending limb, seeking the life they believe is their true destiny. These actions, while driven by profound psychological discomfort, highlight the severity of the condition and the urgency for better understanding and treatment options. However, the ethical and medical challenges involved in accommodating these requests are significant. While there have been rare instances of surgeons performing amputations on BID patients, such decisions remain highly controversial within the medical community. Ultimately, BID sheds light on the complex relationship between body and identity. It challenges our understanding of how the brain constructs the self, and how deeply ingrained this sense of physical congruence is to our mental well-being. While much remains unknown, BID serves as a reminder of the profound diversity in human experience and the need for empathy, research, and thoughtful care. Body dysmorphic disorder. This is a deeply distressing condition that affects the way a person perceives their own appearance. Those who suffer from BDD become preoccupied with one or more perceived flaws in their physical appearance, flaws that often seem minor or unnoticeable to others. Yet, to the person experiencing BDD, these imperfections are overwhelming, dominating their thoughts and emotions and leading to significant impairment in daily life. At its core, BDD is not merely a form of vanity or excessive concern about looks. It's a complex psychological condition rooted in distorted body image and heightened sensitivity to perceived imperfections. For example, someone with BDD may obsess over the shape of their nose, the size of their ears, the condition of their skin, or the symmetry of their features. These preoccupations can consume hours of their day, causing them to repeatedly check mirrors, avoid social situations, or seek reassurance from others. Despite reassurances, they often remain convinced that their perceived flaw is glaring and unacceptable. The exact causes of BDD are not fully understood, but research points to a combination of genetic, neurological, and environmental factors. Some studies suggest that people with BDD may have differences in brain activity related to visual processing, leading them to focus excessively on minor details and exaggerate the significance of perceived flaws. Childhood experiences, such as bullying, teasing, or criticism about appearance, may also contribute to the development of the disorder. Additionally, societal and cultural pressures that place a high value on physical beauty can exacerbate feelings of inadequacy and trigger BDD symptoms. BDD is classified as a type of obsessive-compulsive and related disorder because of the repetitive behaviors and intrusive thoughts associated with it. People with BDD often engage in compulsive actions, such as constant mirror checking, excessive grooming, or comparing themselves to others in an attempt to alleviate their distress. Unfortunately, these behaviors typically reinforce the negative cycle rather than providing relief. Over time, the disorder can lead to isolation, depression, and difficulty maintaining relationships, work, or academic responsibilities. One of the most concerning aspects of BDD is the high risk of co-occurring conditions. Many individuals with BDD also struggle with depression, anxiety, or eating disorders. In severe cases, the intense distress and feelings of worthlessness can lead to suicidal ideation or attempts. This underscores the importance of recognizing the condition early and providing appropriate treatment. Treatment for BDD typically involves a combination of psychotherapy and, in some cases, medication. Cognitive behavioral therapy, CBT, is considered the gold standard, helping individuals identify and challenge distorted thoughts about their appearance, reduce compulsive behaviors, and develop healthier coping strategies. Exposure and response prevention techniques can also help individuals gradually confront situations that trigger their anxiety without resorting to checking or avoidance behaviors. Medications, particularly selective serotonin reuptake inhibitors, SSRIs, may be prescribed to reduce the obsessive thoughts and anxiety associated with BDD. While medication alone is not a cure, it can help alleviate symptoms enough for individuals to fully engage in therapy and begin to make progress. Support groups and peer connections can also be valuable, providing a safe space for individuals to share their experiences and feel less isolated. Ultimately, body dysmorphic disorder highlights the complex relationship between self-perception, mental health, and societal pressures. It serves as a reminder that what we see in the mirror can be profoundly influenced by our minds, and that those struggling with BDD deserve empathy, understanding, and access to effective care. By addressing the underlying psychological factors and challenging distorted beliefs, individuals with BDD can move toward a healthier, more compassionate relationship with themselves and their appearance. Erotomania, de Clérambault's syndrome. Imagine believing with absolute certainty that a distant stranger, someone you've never spoken to, perhaps a celebrity, public figure, or even a former acquaintance, harbors deep romantic feelings for you. This is the hallmark of erotomania, or de Clérambault's syndrome, a rare and deeply troubling delusional disorder. In this condition, the person affected becomes convinced that another individual is secretly in love with them, often interpreting mundane actions or coincidental events as proof of this imagined affection. While the affected person may feel elation and excitement at the thought of being the object of such devotion, the delusion can lead to significant emotional distress and disrupted social functioning. Named after French psychiatrist Gaëtan Gatien de Clérambault, who first described the condition in the early 20th century, erotomania is classified as a delusional disorder of the paranoid type. Unlike fleeting infatuations or fantasies, erotomania is characterized by an unshakable belief that the other person reciprocates their feelings. This belief persists despite overwhelming evidence to the contrary, and it often leads the affected individual to engage in behaviors that they perceive as reciprocating the imagined affection. These behaviors might include sending letters, attempting to make contact, or stalking the other person, actions that can escalate over time and potentially cause harm to both the affected individual and their perceived love interest. The underlying causes of erotomania remain poorly understood, but it is frequently associated with other psychiatric conditions. Schizophrenia, bipolar disorder, and severe depression can all be linked to erotomanic delusions. In some cases, the delusion may be triggered by social isolation, a history of rejection, or underlying feelings of low self-worth. The individual's mind constructs the delusion as a way to cope with feelings of loneliness or to fulfill unmet emotional needs. By imagining that a powerful, admired, or seemingly unattainable person is in love with them, they find a sense of validation and significance that may be missing in their day-to-day life. Treatment for erotomania involves addressing the underlying mental health issues that give rise to the delusion. Antipsychotic medications are often prescribed to to help reduce the intensity of the delusions, while psychotherapy can help the individual develop insight into their condition and adopt healthier thought patterns. Cognitive behavioral therapy, CBT, in particular, can help challenge the core beliefs underlying the erotomanic delusion and encourage more rational interpretations of events. In some cases, treatment may also focus on improving social skills, building self-esteem, and fostering healthier relationships with others. For those experiencing erotomania, the condition can be deeply isolating and confusing. They may struggle to understand why their feelings aren't reciprocated or why others don't see the relationship they believe is so real. Friends and family members may feel powerless to help, especially if the individual resists treatment or remains convinced that their delusion is true. In these situations, a compassionate, non-confrontational approach can be crucial. Encouraging the individual to seek professional help and offering support without reinforcing the delusion is often the best way forward. Erotomania raises profound questions about the nature of love, perception, and reality. It challenges us to consider how the mind can create compelling yet utterly false narratives, and how those narratives can shape a person's emotions, behaviors, and sense of self. For those affected, the journey to recovery involves not only letting go of the imagined relationship, but also rebuilding a stable and fulfilling connection with reality, an often difficult but ultimately life-affirming process. Reduplicative paramnesia. Reduplicative paramnesia is a rare and intriguing neurological condition in which an individual becomes convinced that a place or location has been duplicated, often believing that they are in a copy of the original site. For instance, a person might insist that the hospital room they are lying in is not the real one, but rather an identical replica situated elsewhere. They may even claim that their home has been perfectly recreated in another city, or that the building they are in has been shifted to a different location without their knowledge. This delusion was first identified by neurologist Arnold Pick in 1903 and has since been observed in individuals with certain types of brain damage, particularly involving the right hemisphere and frontal lobes. Reduplicative paramnesia often occurs following head injuries, strokes, or neurodegenerative diseases like Alzheimer's. It is classified as one of the delusional misidentification syndromes, a group of disorders where individuals have distorted perceptions of their surroundings or the people around them. What makes reduplicative paramnesia particularly intriguing is its specificity. Unlike more general delusions or hallucinations, this condition focuses on the physical space and location, blending elements of spatial disorientation with a firm conviction that the environment has been duplicated. Even in the face of clear evidence or logical reasoning, the individual will maintain their belief. To them, the environment appears real, but they are utterly convinced it is not the original. Neurologically, this disorder is thought to arise from a disconnection between various brain regions responsible for processing spatial and memory-related information. Normally, the brain integrates multiple inputs, visual cues, memories, and contextual information to form a cohesive understanding of where we are. In reduplicative paramnesia, disruptions in these pathways lead to a fragmented sense of place, causing the brain to confabulate or fill in the gaps with a delusional explanation. For example, damage to the frontal lobes may impair reasoning and judgment, making the person more susceptible to accepting a delusional belief. Simultaneously, dysfunction in the parietal or occipital lobes might interfere with visual and spatial processing, making familiar locations feel unfamiliar or off. The result is a deeply held conviction that the place they are in is a duplicate, even though it appears identical to the original. Reduplicative paramnesia can have profound consequences for those who experience it. Patients may refuse to accept medical care, insist on being returned to their true home, or become disoriented and anxious in their environment. Caregivers and medical staff may find it challenging to reassure the individual, as logical arguments and explanations often fail to change their beliefs. This can lead to frustration, confusion, and difficulty in providing appropriate care. Treatment for reduplicative paramnesia typically focuses on addressing the underlying neurological condition. In cases where the delusion is linked to a brain injury or stroke, rehabilitation and therapy can help improve overall cognitive function and potentially reduce the severity of the delusion. If the condition is associated with Alzheimer's disease or another form of dementia, caregivers may need to use supportive and reassuring strategies rather than trying to correct the belief directly. Antipsychotic medications are sometimes used if the delusion causes significant distress or leads to dangerous behavior, though their effectiveness in this particular condition varies. For researchers and clinicians, reduplicative paramnesia offers a fascinating window into how the brain constructs our sense of reality. It reveals the intricate interplay between memory, perception, and spatial awareness, and how delicate that balance can be. While rare, this condition underscores the importance of understanding how neurological damage can lead to highly specific and deeply held delusions, and how these delusions challenge our traditional notions of place, identity, and reality itself. Ganser syndrome. Ganser syndrome is a rare and intriguing psychological condition in which an individual gives seemingly deliberate, nonsensical answers to simple questions, yet these responses appear to stem from genuine confusion rather than intentional deceit. For example, if asked how many legs a cow has, the person might confidently respond, 5. Known as approximate answers, these responses often seem close to being correct, but they are not quite right, suggesting that the individual is engaging in a sort of subconscious mimicry of mental illness rather than consciously pretending to be impaired. First identified by the German psychiatrist Sigbert Ganser in 1897, the syndrome is sometimes referred to as prison psychosis because it was initially observed in inmates who appeared to develop psychiatric symptoms while awaiting trial or sentencing. Although it is no longer officially categorized as a standalone disorder, Ganser syndrome is typically regarded as a type of factitious disorder or a dissociative condition. It's not simply malingering, where someone fakes illness for personal gain, nor is it a clear-cut case of psychosis. Instead, the condition occupies a gray area where the person's odd behavior and confusion seem genuine, even if there's no obvious medical or psychiatric cause. Individuals with Ganser syndrome may exhibit a range of other symptoms beyond approximate answers. They might complain of memory problems, show signs of dissociation, or experience hallucinations. Some may appear disoriented or confused, and others might display exaggerated emotional reactions. These symptoms often arise in response to extreme stress, trauma, or a situation where the person feels trapped or overwhelmed. In this sense, Ganser syndrome can be seen as a psychological defense mechanism, an unconscious way of coping with intolerable circumstances by checking out from reality and adopting a state of confusion. The condition is most often observed in settings where the individual is under pressure, such as in legal situations, during incarceration, or following a traumatic event. While it is rare, Ganser syndrome highlights the mind's complex ability to produce symptoms that are neither fully voluntary nor entirely involuntary. The person experiencing it is not consciously faking their confusion, yet the pattern of responses and behaviors clearly suggests a psychological origin rather than an organic one. Diagnosis can be challenging, as Ganser syndrome mimics other psychiatric and neurological conditions. Careful evaluation by a mental health professional is essential to rule out other causes of the symptoms, such as brain injury, psychotic disorders, or malingering. Once other conditions have been excluded, the diagnosis often rests on recognizing the unique pattern of approximate answers, the presence of dissociative features, and the context in which the symptoms emerged. Treatment for Ganser syndrome typically involves addressing the underlying stressors or psychological conflicts that may have triggered the condition. Psychotherapy, especially approaches that focus on trauma or stress management, can help the individual process their emotions and regain a clearer sense of reality. Supportive therapy and building trust with the therapist are crucial, as individuals with Ganser syndrome may be reluctant to acknowledge the underlying issues that led to their symptoms. In some cases, short-term use of medication for anxiety or depression may be helpful, though the primary focus is on psychotherapy and environmental support. Ganser syndrome serves as a fascinating example of how the mind can respond to overwhelming stress in unexpected and unusual ways. It blurs the line between deliberate deception and genuine confusion, prompting questions about the interplay of consciousness, stress, and identity. Though rare, the syndrome offers valuable insights into the mind's ability to generate complex and puzzling symptoms as a means of coping with a world that feels impossible to navigate. Shared psychotic disorder, folie à deux. Imagine living closely with someone whose beliefs become so pervasive and convincing that you begin to adopt them yourself. Over time, their delusions start to seem real, so much so that you no longer see them as false. This phenomenon, known as shared psychotic disorder or folie à deux, literally madness of two, occurs when two or more individuals share the same delusional system, often with one person as the dominant source of the belief. The condition blurs the boundaries between individuality and influence, revealing how deeply our mental states can be shaped by those around us. The defining feature of shared psychotic disorder is the transmission of delusions from one person, sometimes referred to as the primary or inducer, to another individual who is more susceptible. The second person, or secondary, typically has a close relationship with the primary individual, such as a spouse, sibling, parent, or caregiver. In rarer cases, the delusion may spread to multiple individuals within a tightly knit group, creating what is called folie à trois, folie à quatre, and so on, depending on the number of people involved. Shared psychotic disorder usually develops gradually, as the secondary individual becomes more isolated and dependent on the primary person. Over time, they may lose their ability to critically evaluate the delusional beliefs and come to accept them as reality. The delusion itself can take many forms: paranoia about a conspiracy, belief in supernatural phenomena, or even complex narratives about persecution or hidden messages. Regardless of the content, the shared delusion creates a self-reinforcing cycle where each person validates the other's beliefs, making them even more entrenched. The condition is most commonly seen in relationships where one person exerts a strong influence over the other. The primary individual often has a more dominant personality or a pre-existing psychotic disorder, while the secondary individual may be more passive, emotionally dependent, or socially isolated. This dynamic allows the delusional belief to take root and flourish in the absence of outside perspectives. Factors such as stress, close physical proximity, and a lack of alternative social support can further strengthen the bond and solidify the shared delusion. Although shared psychotic disorder is rare, it poses significant challenges for diagnosis and treatment. The close emotional connection between the individuals involved can make it difficult for mental health professionals to separate the primary and secondary contributors or to determine where the delusion originated. In some cases, the secondary individual may initially appear to have a separate psychotic disorder, but upon closer examination, their beliefs are found to mirror those of the primary individual. Treatment typically involves separating the individuals involved in the shared delusion, at least temporarily. Once they are apart, the secondary person often begins to recognize that the delusion was not their own and may experience a gradual return to reality. For the primary individual, treatment usually focuses on addressing the underlying psychotic disorder, often through antipsychotic medications and psychotherapy. Supportive therapy can also help the secondary individual rebuild their sense of independence, improve their self-esteem, and reintegrate into a broader social network. Shared psychotic disorder offers a compelling glimpse into the power of human relationships and the ways in which our perceptions of reality can be influenced by those closest to us. It underscores the importance of critical thinking, social connections, and maintaining a diverse range of perspectives to prevent undue influence. At its heart, Folie à deux is a reminder that our mental worlds are not always as isolated as they might seem, that our beliefs, even the delusional ones, can be profoundly shaped by the people with whom we share our lives. Pseudocesis, false pregnancy. Pseudocesis, also known as false pregnancy, is a rare condition in which an individual firmly believes they are pregnant and even exhibits many of the physical and emotional symptoms associated with pregnancy, despite not actually being pregnant. This phenomenon can be deeply distressing and bewildering, as those affected are convinced of their condition, and their bodies often appear to confirm their belief. Pseudociesis blurs the lines between mind and body, illustrating the profound influence of psychological factors on physiological responses. The symptoms of pseudociesis can be strikingly similar to those of a genuine pregnancy. A person may experience abdominal enlargement, cessation of menstruation, morning sickness, breast tenderness, and even sensations of fetal movement. In some cases, their body may produce certain hormones or mimic other biochemical markers typically seen in pregnancy. These symptoms are not consciously faked or imagined. They feel entirely real to the person experiencing them. The belief in pregnancy can be so strong that even negative pregnancy tests or ultrasounds might not immediately dissuade them. Pseudociesis is believed to arise from a complex interplay of psychological, emotional, and hormonal factors. It often occurs in individuals who have a strong desire for pregnancy, perhaps due to social or cultural pressures, unresolved grief, or an intense longing for parenthood. In other cases, fear of pregnancy or deep anxiety about reproductive health may paradoxically trigger symptoms that mimic pregnancy. The condition has also been reported in individuals who have experienced multiple miscarriages or infertility, where the emotional strain of these experiences manifests in a belief that they are finally pregnant. The mind-body connection in pseudociesis highlights how deeply intertwined our psychological states are with our physical health. Stress, hormonal imbalances, and deeply held emotions can prompt the body to produce physical signs of pregnancy, such as weight gain, swelling, or even the enlargement of the uterus. This physiological response reinforces the person's belief, creating a cycle that can be difficult to break without professional intervention. Treatment for pseudocyesis typically involves addressing the underlying psychological and emotional factors. Psychotherapy, particularly cognitive behavioral therapy, CBT, can help individuals explore the reasons behind their belief and develop healthier ways to cope with their emotions. Support groups or counseling may provide additional emotional support and help reduce feelings of isolation. In some cases, medication may be used to manage associated depression or anxiety, but the primary focus is on guiding the person toward understanding and accepting their situation. In rare instances, pseudocyesis may also be linked to medical conditions that mimic pregnancy symptoms. Thyroid disorders, ovarian tumors, or certain hormonal imbalances can cause changes in the body that resemble pregnancy. For this reason, a thorough medical evaluation is often recommended to rule out any physical causes before focusing solely on psychological treatment. Pseudocyesis is not just a medical curiosity. It's a vivid example of how the mind can shape our physical experiences. It underscores the importance of compassionate care, as those experiencing pseudocyesis are not simply imagining their symptoms. They are grappling with a complex and often deeply emotional condition. By addressing both the psychological and physiological aspects of the disorder, healthcare providers can help individuals regain a sense of balance and move forward with greater understanding and self-awareness. Alien hand syndrome. Alien hand syndrome is a rare neurological condition in which a person's hand appears to move or act independently of their conscious control. Those affected often feel as though their hand is foreign or no longer under their command, leading to seemingly purposeful movements that can feel startling or unsettling. For example, the hand may pick up objects, touch the face, or even resist the movements of the other hand, as if it has a will of its own. The syndrome most commonly occurs following brain surgery, stroke, or trauma that affects the corpus callosum, the bundle of nerve fibers that connects the brain's left and right hemispheres. It can also arise from damage to the parietal lobe, the frontal lobe, or other areas involved in motor control and sensory integration. When communication between these regions is disrupted, the normal coordination and regulation of hand movements can break down, resulting in involuntary or unexpected actions. One of the hallmark features of alien hand syndrome is the sensation of disconnection from the affected hand. The individual knows the hand is theirs, but it feels foreign, almost as though it belongs to someone else. In some cases, the hand may perform tasks that the person finds inconvenient or distressing, such as unbuttoning a shirt that the other hand is trying to button, or grabbing objects without intention. The movements often seem deliberate, even though the person does not will them to happen. Alien hand syndrome highlights the complex neural mechanisms behind voluntary movement and our sense of bodily ownership. Normally, the brain's motor and sensory systems work together seamlessly, allowing us to move our limbs intentionally and feel that they are part of our body. When these systems are disrupted, the hand's movements can become uncoordinated or automatic, creating the perception of an alien entity. This disconnection also underscores how deeply our sense of self is tied to the brain's ability to integrate motor commands and sensory feedback. Treatment for alien hand syndrome can be challenging, as the condition is not caused by psychological factors or a lack of effort to control the hand. Instead, therapy focuses on retraining the brain and improving coordination. Occupational therapy, physical therapy, and behavioral strategies are often used to help individuals manage the hand's movements. For example, some patients learn techniques to keep the hand occupied or to redirect its motions. In rare cases, medications or additional interventions may be considered, but the primary goal is to improve function and reduce the distress caused by the hand's actions. Although it is a rare condition, alien hand syndrome has been a subject of fascination for both scientists and the public. Its strange and dramatic symptoms raise profound questions about free will, autonomy, and the neural underpinnings of our sense of self. The syndrome serves as a stark reminder of how intricate and interconnected the brain's systems are, and how, when they are disrupted, even the most basic aspects of our bodily awareness can become fragmented and unfamiliar. Stendhal syndrome. This is a rare and fascinating psychological condition that occurs when an individual is overwhelmed by the beauty of art or a particularly intense cultural experience. Named after the 19th century French writer Stendhal, who described feeling dizzy, faint, and emotionally overcome while viewing Renaissance masterpieces in Florence. The syndrome reflects the profound impact that great art and cultural heritage can have on the human psyche. For those who experience it, the symptoms can be both thrilling and deeply unsettling, transforming a simple museum visit or sightseeing tour into a moment of psychological intensity. The symptoms of Stendhal syndrome often include rapid heartbeat, dizziness, fainting, confusion, anxiety, and even hallucinations. In some cases, individuals report feeling a sense of depersonalization or an overwhelming flood of emotions that they struggle to process. These reactions typically occur in the presence of extraordinary artistic works, majestic architecture, or culturally significant sites, such as Michelangelo's David, the Sistine Chapel, or the grandeur of Florence's Uffizi Gallery. The syndrome is not limited to any one specific type of art. It can be triggered by paintings, sculptures, music, or even natural beauty and cultural settings that evoke a strong emotional or aesthetic response. While Stendhal syndrome is not officially recognized as a medical diagnosis in major psychiatric manuals, it has been widely discussed by clinicians, cultural historians, and art lovers alike. The condition highlights the deep connection between art, emotion, and the human mind. One explanation is that individuals who experience Stendhal syndrome may be highly sensitive or empathetic, allowing them to feel a stronger emotional resonance with the works they encounter. The sheer concentration of beauty and history in a particular place, such as Florence, can create a sensory and emotional overload, especially for those who are unaccustomed to experiencing art on such a scale. Another theory is that the syndrome is a form of acute stress response triggered by an overwhelming aesthetic experience. The intensity of the artwork or cultural site can stimulate heightened arousal in the brain's limbic system, which regulates emotions, and the prefrontal cortex, which processes aesthetic appreciation. When these brain regions are overstimulated, the individual may feel a loss of control, resulting in the symptoms commonly associated with Stendhal syndrome. This idea aligns with the broader understanding of how the brain processes beauty and emotional meaning, revealing just how powerful art can be in shaping our internal states. Interestingly, Stendhal syndrome is most often reported in tourists or visitors who encounter great art or cultural landmarks for the first time. This suggests that the novelty and significance of the experience, combined with the individual's pre-existing expectations, play a role in triggering the condition. Those who are deeply moved by the cultural heritage of a place may find themselves completely enveloped by its beauty, leading to the intense emotional and physical reactions described in the syndrome. Managing Stendhal syndrome involves recognizing its temporary nature and understanding that the overwhelming emotions it provokes are not harmful, but rather a testament to the profound impact that art and culture can have. In severe cases, stepping away from the stimulus, practicing deep breathing, or sitting in a quiet space can help ground the individual. Long-term strategies may include learning to pace oneself when visiting museums or historic sites, as well as cultivating a mindful approach to art appreciation, one that allows for reflection and integration of the emotional experience without becoming overwhelmed. Stendhal syndrome serves as a compelling reminder of the power of art and culture to move us in unexpected ways. It underscores the emotional and psychological dimensions of aesthetic appreciation, revealing how deeply art can resonate within the human soul. For those who experience it, the syndrome can be as much a gift as a challenge, offering a rare glimpse into the transformative potential of beauty and the enduring impact of human creativity. Jerusalem Syndrome. Imagine visiting a place of profound religious and historical significance, walking through ancient streets, breathing in the air of holy sites, and suddenly feeling a deep, inexplicable shift within yourself. You may find that your thoughts grow more intense, your emotions swell, and you begin to believe that you are destined to fulfill a divine purpose. For some, this experience becomes so overwhelming that it leads to what is known as Jerusalem Syndrome, a rare psychological phenomenon where visitors to Jerusalem exhibit sudden, intense religious or spiritual delusions. Jerusalem Syndrome is unique in that it appears to be triggered specifically by the city's rich spiritual history and significance to Judaism, Christianity, and Islam. Those affected often have no prior history of mental illness and arrive as ordinary tourists, yet they quickly develop a powerful sense of personal connection to religious narratives. Common behaviors include adopting biblical or messianic personas, delivering impromptu sermons, quoting scripture with newfound fervor, or undertaking symbolic acts, such as donning white robes or preparing a sacred ritual. In some cases, individuals believe they have been chosen by a higher power to fulfill a prophecy or bring about divine intervention. What makes Jerusalem Syndrome particularly fascinating is its apparent link to the city itself. While many cities evoke emotional and spiritual responses, Jerusalem's layers of religious significance, its deeply charged atmosphere, and its centuries of pilgrimage history seem to amplify these effects. Visitors who have been steeped in religious traditions or who carry strong personal beliefs may find that their expectations and emotional responses become heightened upon entering the city's sacred spaces. The sheer weight of history, faith, and cultural meaning can create a psychological tipping point for those already predisposed to intense religious experiences. Interestingly, not everyone who experiences Jerusalem Syndrome has a pre-existing psychiatric condition. While some individuals may have underlying mental health issues that are exacerbated by the city's environment, others appear to develop the syndrome spontaneously, driven by the intensity of the spiritual and cultural setting. Psychologists who have studied the phenomenon note that it typically resolves after the individual leaves Jerusalem and returns to their usual surroundings. This suggests that the syndrome may be a transient response to the city's unique atmosphere rather than a chronic mental illness. The syndrome is generally divided into three main types. The first involves individuals who have an established history of mental illness and are drawn to Jerusalem by their pre-existing delusions. The second includes those who have underlying personality traits or obsessive religious ideas that are heightened by their pilgrimage. The third and most curious type involves otherwise mentally healthy visitors who suddenly experience acute religious delusions during their time in the city. These individuals may have no prior indications of psychological distress, yet they find themselves swept up in a wave of fervent belief and symbolic behavior. Treatment for Jerusalem syndrome typically involves removing the individual from the environment that triggered the episode and providing reassurance and support. In many cases, the symptoms subside on their own once the person returns home. For those with underlying psychiatric conditions, a combination of therapy and, if necessary, medication can help manage symptoms and prevent recurrence. The key is to approach each case with understanding and empathy, recognizing that the person's experiences, while deeply distressing, are rooted in a complex interplay of psychological, cultural, and spiritual factors. Jerusalem syndrome serves as a reminder of the powerful connection between place, belief, and identity. It illustrates how our surroundings, especially those steeped in religious and historical significance, can profoundly shape our emotions and perceptions. For those who experience it, the syndrome can be both a deeply unsettling and transformative event, challenging our understanding of how spirituality, culture, and the human mind interact. Paris syndrome. Picture a long-anticipated journey to one of the world's most iconic cities, a place renowned for its beauty, romance, and charm. You've spent years envisioning strolls along the Seine, visits to the Eiffel Tower, and the seemingly effortless elegance of Parisian life. Yet upon arrival, you find yourself overwhelmed by stress, disillusionment, and a profound sense of disappointment. This disorienting experience is known as Paris syndrome, a rare psychological phenomenon in which visitors, most often tourists from abroad, experience intense feelings of anxiety, confusion, and even hallucinations upon visiting Paris. Paris syndrome is especially associated with travelers who have an idealized image of the city, often shaped by movies, literature, and advertising. Before their trip, they might imagine a city filled with romance, artistic inspiration, and sophisticated charm. A place where every cafe is picturesque and every interaction is warm and inviting. But when confronted with the realities of urban life, crowded streets, hurried locals, cultural differences, and occasional indifference, they may feel a sharp disconnect between expectation and reality. This emotional dissonance can trigger a range of psychological and physical symptoms, including panic attacks, dizziness, delusions, and a sense of unreality. The syndrome was first identified in the late 20th century by Japanese psychiatrists, who noticed that some of their patients developed acute psychological distress while visiting Paris. While it is not limited to any single nationality, Paris syndrome is most commonly reported among Japanese tourists, likely due to cultural differences in communication, behavior, and expectations. In Japanese culture, politeness and formality often play a central role in social interactions, so the perceived brusqueness or hurried demeanor of some Parisians might be interpreted as rudeness or hostility, further heightening feelings of isolation and stress. In many cases, individuals experiencing Paris syndrome report that the city feels alienating rather than welcoming. The sheer scale and complexity of Paris, combined with jet lag, language barriers, and the pressure to meet high expectations, can create a perfect storm for emotional overwhelm. For some, the symptoms become so severe that they seek medical assistance or decide to cut their trip short. In rare cases, hospitalization is required to stabilize their mental state before they can return home. Treatment for Paris syndrome typically involves rest, reassurance, and, if necessary, short-term psychological support. In many cases, simply leaving the city or taking a break from sightseeing helps alleviate the symptoms. For those who are more severely affected, counseling or therapy may help them process their feelings of disappointment and regain a sense of perspective. It's also worth noting that once tourists adjust their expectations and settle into a more balanced view of Paris, the symptoms often subside on their own. Paris syndrome sheds light on the powerful role that expectations and cultural context play in shaping our emotional experiences. It's not just about Paris itself, but rather the gap between the fantasy of the city and the realities of modern urban life. For those affected, the syndrome can feel disorienting and upsetting, but it ultimately reminds us of the importance of approaching new places and life itself with an open mind, realistic expectations, and a willingness to embrace the unexpected. Clinical lycanthropy, werewolf syndrome. Clinical lycanthropy is an extremely rare psychiatric condition in which individuals believe they can transform into animals, most famously, werewolves. While the term evokes folklore and myth, the condition is not about sprouting fur or howling at the moon. Instead, those with clinical lycanthropy experience a deeply ingrained delusion. They are convinced that they have already transformed into, or are in the process of transforming into, a non-human creature. This belief is more than mere imagination. People with clinical lycanthropy may perceive physical changes, believing, for instance, that their teeth have lengthened, their bodies have become more muscular, or their hair has grown unnaturally. They may exhibit animal-like behaviors such as growling, crawling on all fours, or behaving aggressively. These experiences feel real to them, even though there is no actual physical transformation taking place. Historically, lycanthropy was linked to cultural folklore and witch trials, with accused individuals claiming to have transformed into wolves or other creatures under supernatural influence. Today, clinical lycanthropy is recognized as a psychiatric phenomenon rather than a supernatural one. It often occurs alongside other mental health conditions, such as schizophrenia, bipolar disorder, or severe depression. In some cases, it may also be associated with neurological disorders, substance use, or brain injuries. The condition is thought to arise from disruptions in the brain regions responsible for self-perception, body image, and identity. The exact cause of clinical lycanthropy remains unclear, but some theories suggest that it may be related to a form of dissociation or delusional misidentification syndrome, similar to Capgras or Fregoli delusions, in which individuals misidentify people or places. Clinical lycanthropy involves a misidentification of one's own physical self. The person's brain processes distorted sensory information, leading them to interpret normal bodily sensations as evidence of transformation. For instance, heightened emotional states or stress could cause muscle tension or changes in heartbeat, which the individual may interpret as the beginning of an animal transformation. Despite its rarity, clinical lycanthropy has fascinated psychiatrists, neurologists, and cultural historians alike. Each reported case sheds light on the intricate connections between mind, body, and self-perception. For those experiencing the condition, the belief in their transformation can be distressing and isolating. It may cause them to withdraw from social interactions or lead them to engage in risky or harmful behaviors. In some instances, individuals have sought help because they feared they might harm others, believing themselves to be dangerous animals. Treatment for clinical lycanthropy focuses on addressing the underlying psychiatric or neurological condition. Antipsychotic medications, mood stabilizers, or antidepressants may be prescribed, depending on the individual's diagnosis. Psychotherapy, particularly cognitive behavioral therapy, CBT, can help patients challenge their delusional beliefs and gradually reconnect with their true sense of self. For some, understanding the neurological and psychological underpinnings of their experience can provide relief and reduce the intensity of the delusion. Support from family, friends, and mental health professionals is also crucial in helping the individual feel grounded and understood. Clinical lycanthropy demonstrates the profound ways in which the human mind can reshape reality. It is a reminder that our perceptions, while typically reliable, are ultimately constructed by a complex network of brain functions that can occasionally falter. For those affected, it can feel as though their very identity is slipping away into something unfamiliar. And yet, through compassionate care and informed treatment, many individuals are able to reclaim their sense of self and live fulfilling lives. Intermetamorphosis. Intermetamorphosis is a rare and puzzling delusional misidentification syndrome in which individuals believe that the people around them have physically transformed into someone else. Unlike the well-known Capgras delusion, which involves the belief that a loved one has been replaced by an identical imposter, intermetamorphosis is more complex. The person doesn't see an imposter, but rather perceives a genuine transformation. For instance, a spouse might appear to morph into a sibling, a friend might seem to turn into a co-worker, or a doctor may suddenly be recognized as a family member. In the person's mind, these changes are not imagined. They are experienced as real and deeply unsettling. This condition is more than simple confusion or a case of mistaken identity. Individuals with intermetamorphosis often have a strong conviction that these transformations are actually happening, despite all evidence to the contrary. Their perception becomes so distorted that they may withdraw from relationships, avoid certain people, or even become suspicious or fearful of those they previously trusted. The delusion can cause significant distress and disruption in their personal and social lives as they struggle to reconcile these shifting identities with their own memories and experiences. Intermetamorphosis is often associated with neurological conditions or psychiatric disorders. It may occur in individuals with schizophrenia, dementia, or brain injuries, particularly those affecting regions responsible for facial recognition, memory, and emotional processing. When these neural systems fail to function properly, the brain's internal catalog of people's faces and roles can become scrambled. This disruption leads to the perception that one person has become another, rather than simply appearing unfamiliar or being misidentified as someone entirely different. The syndrome is thought to arise from a combination of impaired visual and emotional recognition. Normally, the brain integrates facial features, voice patterns, and contextual cues to create a cohesive sense of who someone is. When that integration breaks down, due to damage or dysfunction in areas such as the fusiform face area or the right temporal lobe, individuals may lose the ability to consistently recognize a person's true identity. Instead, they rely on fragmented, incorrect associations, leading to the delusion that one person has literally transformed into another. Treatment for intermetamorphosis typically involves addressing the underlying condition. Antipsychotic medications or mood stabilizers may help reduce the intensity of the delusion in individuals with schizophrenia or other psychotic disorders. In cases involving neurological injury or dementia, therapeutic interventions often focus on improving overall cognitive function and providing supportive care. Psychotherapy, while challenging in the context of such fixed beliefs, can help individuals develop coping strategies, reduce anxiety, and re-establish trust in their relationships. Building a strong therapeutic alliance is essential, as the person's delusions often make them skeptical of others' intentions and hesitant to accept help. Intermetamorphosis, like other delusional misidentification syndromes, highlights the fragile nature of our sense of identity and reality. It demonstrates how our brains rely on a delicate balance of sensory input, memory, and emotional connection to construct the world around us. When that balance is disrupted, even the most familiar faces can seem foreign, and the people closest to us can feel like strangers, or in this case, like someone entirely different. Foreign accent syndrome. Foreign accent syndrome, FAS, is a rare neurological condition in which a person suddenly starts speaking with an accent that is perceived as foreign or distinctly different from their usual speech patterns. This change is not intentional or the result of language immersion. Rather, it often emerges after a head injury, stroke, or other brain-related condition. What makes FAS so fascinating, and at times deeply unsettling for those affected, is that the new accent is not a perfect imitation of another language's phonetic patterns. Instead, it's a distorted version of the person's native speech, shaped by subtle changes in the way their brain controls the muscles involved in speaking. People with foreign accent syndrome might find themselves sounding British, French, Spanish, or even like a speaker of an entirely unrelated language. However, linguistic analysis usually reveals that their new speech pattern doesn't match the true phonetic characteristics of any specific accent. Instead, it's a unique blend of vowel shifts, altered consonants, and changes in rhythm and intonation that gives the impression of a foreign accent. To those who hear it, the speech sounds authentically different, but to the individual experiencing it, the change can feel deeply disorienting and out of their control. The most common cause of FAS is a stroke, particularly one that affects the brain regions responsible for speech production and motor control, such as Broca's area or the motor cortex. Other causes include traumatic brain injuries, brain tumors, multiple sclerosis, and even certain psychiatric conditions. In rare cases, no clear cause is found, leaving doctors and researchers puzzled as to why the person's speech pattern suddenly shifts. FAS highlights the intricate connection between the brain's motor functions, language centers, and the fine muscle coordination required for speech. When these systems are disrupted, the subtle shifts in articulation, stress, and intonation that define a person's native accent can become scrambled. The result is speech that may sound foreign to listeners, even though the person still speaks their original language, uses the same vocabulary, and follows the same grammar rules. Living with foreign accent syndrome can be challenging, both emotionally and socially. Many people find the sudden change in their speech identity to be distressing, as it can feel like they've lost a part of themselves. Friends, family, and colleagues may have difficulty adjusting, which can lead to awkward interactions or misunderstandings. In some cases, people with FAS feel isolated or self-conscious about speaking in public, worried that others will judge or misinterpret their speech as affected or fake. Treatment for FAS often focuses on addressing the underlying cause, such as therapy and rehabilitation after a stroke, or managing the symptoms of a neurological condition. Speech therapy can help individuals regain control over their articulation and work toward a more familiar speech pattern. While it may not always be possible to fully restore their original accent, therapy can improve intelligibility and reduce the emotional distress associated with the condition. Psychological counseling or support groups can also help individuals cope with the social and emotional impact of FAIS. Foreign accent syndrome is an extraordinary reminder of how complex and delicate the mechanisms of speech production are. It challenges our understanding of identity and communication, showing how something as seemingly simple as an accent is the result of intricate brain processes. For those who experience it, FAIS is more than just a curious anomaly. It's a profound, often disorienting shift in how they relate to the world and how the world perceives them. Lata is a unique cultural phenomenon that manifests as an exaggerated startle response, followed by a series of involuntary behaviors or vocalizations. Most commonly reported in certain Southeast Asian cultures, particularly in Malaysia, Indonesia, and parts of Thailand, lata occurs when individuals, typically middle-aged or older women, are startled by a sudden sound, touch, or movement. In these moments, they may shout unexpected phrases, mimic the words or actions of those around them, or perform gestures that they later report having little control over. While the condition is often seen as a cultural or social reaction rather than a purely medical one, it provides a fascinating look into how culture, psychology, and neurology can intersect. What distinguishes lata from a simple startle response is the elaborate sequence of behaviors that follows. After being startled, individuals may experience echolalia, repeating words spoken by others, echopraxia, mimicking another's gestures, or even involuntary swearing or inappropriate comments. In some cases, they may obey commands without hesitation, even if the request is absurd or socially unacceptable. These reactions are not deliberate. Those who experience lata often express confusion or embarrassment after the episode, noting that they felt compelled to act without their usual control. Lata has long intrigued researchers and anthropologists because of its strong cultural component. In societies where lata is recognized, individuals who display these exaggerated startle responses are sometimes regarded with a mix of amusement and respect, and their reactions may become a form of social entertainment. People may deliberately startle someone they know is prone to lata, resulting in a brief and socially accepted performance of these involuntary behaviors. This cultural reinforcement may help explain why lata appears more frequently in certain regions and less commonly elsewhere. In communities where it is acknowledged, it becomes part of the social fabric, blending elements of humor, tradition, and shared understanding. From a neurological perspective, the startle response involved in lata may be linked to an overactive reflex arc or heightened sensitivity in the brain's alertness and stress response systems. While the behaviors that follow the startle are culturally influenced, the initial exaggerated reaction could stem from underlying neural mechanisms. It's as if the brain's natural startle reflex becomes amplified, making the individual more vulnerable to suggestion or mimicry immediately after being startled. Because lata is so closely tied to cultural context, it has been challenging to fit it into a clear medical or psychiatric framework. Some researchers have considered it a culture-bound syndrome, a condition that arises in specific cultural environments due to shared beliefs, norms, and practices. In other words, while the neurological startle response might be universal, the way it unfolds as lata is shaped by the cultural meaning and social reinforcement surrounding it. Treatment or intervention is rarely sought for lata, as it is generally viewed more as a cultural phenomenon than a medical problem. Those who experience it often live in communities where lata is understood and accepted, reducing any sense of stigma. However, for individuals who find their episodes distressing or disruptive, mindfulness-based strategies or relaxation techniques might help reduce the frequency or intensity of startle responses. Encouraging a supportive environment and minimizing situations that trigger excessive startling can also help improve the individual's comfort and quality of life. Lata is a reminder that the line between culture and biology is often blurred. It illustrates how social environments, expectations, and traditions can shape the expression of psychological and physiological responses. By studying phenomena like lata, we gain insight into the intricate relationship between the brain, behavior, and the cultural worlds we inhabit. Othello syndrome. Delusional jealousy. Othello syndrome, also known as delusional jealousy, is a rare psychiatric condition in which an individual becomes consumed by the unfounded belief that their partner is being unfaithful. Named after the tragic Shakespearean character Othello, who is driven to violence by his belief in his wife's infidelity, this syndrome reflects the destructive power of delusional thinking when it centers on intimate relationships. Those affected by Othello syndrome can become fixated on imaginary evidence of betrayal, often interpreting the smallest details, a glance, a missed phone call, a change in routine, as proof of their partner's supposed infidelity. Unlike ordinary jealousy, which arises from real or perceived threats to a relationship, Othello syndrome is characterized by delusions. The affected person clings to their suspicions despite a lack of factual evidence and even in the face of clear counter-arguments. Their belief can be so strong that they might compulsively check their partner's belongings, read their messages, follow them, or interrogate them repeatedly. This obsessive behavior not only causes significant distress to the individual with the syndrome, but can also place tremendous strain on their relationship, often leading to emotional conflict, social isolation, or even the end of the partnership. The exact cause of Othello syndrome isn't fully understood, but it is frequently associated with underlying psychiatric conditions or neurological disorders. It may occur in the context of schizophrenia, bipolar disorder, or other psychotic illnesses where delusional thinking is a hallmark symptom. Certain neurological conditions, such as brain injuries, Parkinson's disease, or dementia, have also been linked to the syndrome, particularly when they affect regions of the brain involved in judgment, impulse control, and emotional regulation. From a psychological perspective, Othello syndrome may also stem from deep-seated insecurities, low self-esteem, or unresolved attachment issues. People with a history of abandonment or past infidelity experiences might be more vulnerable to developing pathological jealousy, especially if they also have a tendency toward obsessive or paranoid thinking. When these emotional vulnerabilities combine with psychiatric or neurological factors, they can create a perfect storm that fuels the delusional conviction of infidelity. Treatment for Othello syndrome typically involves addressing the underlying causes of the delusions. Antipsychotic medications may help reduce the intensity of delusional thoughts, especially when the syndrome is associated with psychosis or schizophrenia. If mood instability or anxiety plays a role, antidepressants or mood stabilizers may also be prescribed. Psychotherapy, particularly cognitive behavioral therapy, CBT, can help individuals identify and challenge their irrational beliefs, develop healthier ways of thinking, and learn to cope with feelings of jealousy or insecurity. Family or couples therapy may also be beneficial, as it can provide a safe space to rebuild trust and improve communication. In severe cases, the delusions and behaviors associated with Othello syndrome can escalate to dangerous levels, leading to verbal or physical aggression. Early intervention is crucial to prevent harm and to help both the affected individual and their partner navigate the challenges posed by the condition. Support networks, including mental health professionals, family members, and trusted friends, can play an essential role in encouraging treatment and maintaining a supportive environment. Othello syndrome is a vivid example of how our most intimate relationships can become entangled with distorted thoughts and delusions. It underscores the importance of understanding the interplay between mental health, emotional well-being, and interpersonal trust. With proper care, individuals with Othello syndrome can regain stability, strengthen their relationships, and find relief from the consuming grip of delusional jealousy. Dot syndrome. Dot syndrome is a culturally bound psychological condition that involves intense anxiety and somatic symptoms stemming from the belief that one is losing semen. Most commonly reported in South Asia, particularly in India, this condition often manifests in young men who feel weak, tired, or physically unwell because they believe their semen, their vital essence, is being lost through nocturnal emissions, masturbation, or even urine. The condition's symptoms are not simply physical. They include significant emotional distress, guilt, shame, and preoccupation with one's sexual health. The term dhaat derives from the Sanskrit word dhatu, which can mean elixir or essence in traditional Ayurvedic thought. In this cultural context, semen is often regarded as a vital fluid that takes great energy and effort for the body to produce. As a result, any loss of semen is perceived not merely as a physical event, but as a depletion of the body's core vitality. This belief, passed down through generations and reinforced by cultural norms, can lead to overwhelming feelings of inadequacy, weakness, and despair. The symptoms of dhaat syndrome extend beyond physical fatigue. Individuals may experience dizziness, palpitations, backache, and a general sense of nerve weakness. They often ruminate on their perceived loss of strength and health, which further exacerbates their distress. In many cases, the syndrome is linked to a cycle of anxiety. The belief in semen loss causes worry, which in turn amplifies the physical sensations that the person interprets as evidence of even greater loss. Over time, this can become a self-perpetuating pattern that significantly impacts their quality of life. Dhaat syndrome is considered a culture-bound condition because it arises within a specific set of cultural beliefs and medical traditions. It is less common in Western settings, where semen loss is not typically viewed as a health concern. Instead, the condition's prevalence in South Asian societies reflects the local cultural and historical understandings of sexuality, masculinity, and health. In these contexts, young men may lack access to accurate sexual education and instead rely on traditional knowledge or misinformation, which can heighten their fears and misunderstandings about their own bodies. Although not officially recognized in major psychiatric manuals like the DSM or ICD, Dhaat syndrome is frequently encountered in clinical practice in South Asia. It is typically treated as a form of somatization disorder, in which psychological distress is expressed through physical symptoms. The underlying issues often include anxiety, depression, or guilt related to sexual activity or masturbation. In many cases, feelings of inadequacy or failure to meet societal expectations of masculinity contribute to the emotional turmoil. Treatment approaches for Dhaat syndrome focus on education, reassurance, and counseling. A key component is helping the individual understand that semen loss is a natural bodily process and that it does not lead to the dire consequences they fear. Educating patients about basic human physiology, sexual health, and the myths surrounding semen can greatly reduce their anxiety. Cognitive behavioral therapy, CBT, can help individuals challenge their irrational beliefs, manage their anxiety, and break the cycle of rumination. In some cases, medication may be prescribed to address underlying depression or severe anxiety symptoms. Dat syndrome offers a striking example of how cultural beliefs and psychological factors can intertwine to create profound distress. It highlights the importance of culturally sensitive care. Approaches that respect the patient's worldview while gently introducing evidence-based information to alleviate their fears. With appropriate intervention, individuals experiencing Dat syndrome can overcome their symptoms, regain confidence in their health, and move toward a more balanced understanding of their bodies and their well-being. Piblokto, Arctic hysteria. Piblokto, sometimes referred to as Arctic hysteria, is a rare culture-bound syndrome most commonly reported among the Inuit peoples living in the Arctic regions of North America. The condition is characterized by sudden, dramatic episodes of extreme behavior, followed by periods of amnesia or confusion. These episodes often occur in the depths of winter, when the harsh environment and prolonged darkness create conditions of isolation and stress. While it is no longer as commonly reported as in earlier anthropological accounts, Piblokto remains a fascinating example of how cultural, environmental, and psychological factors can converge to produce unique mental health phenomena. Episodes of Piblokto can be intense and unpredictable. Those affected may suddenly begin screaming, tearing off their clothes in sub-zero temperatures, running outdoors, throwing objects, or mimicking animal behavior. These actions seem to emerge without clear provocation and can last anywhere from a few minutes to several hours. Afterward, the individual often has little to no memory of the event. The surrounding community typically responds with a blend of concern and acceptance, viewing the behavior not as madness, but as a temporary, culturally understood reaction to environmental and social stressors. The exact causes of Piblokto remain uncertain, but researchers have proposed several contributing factors. The extreme cold and darkness of the Arctic winter can lead to a kind of sensory and emotional deprivation, heightening stress and anxiety. Nutritional deficiencies, particularly a lack of vitamin D and certain essential fatty acids, have also been suggested as potential contributors. These factors, combined with social isolation, may create a psychological environment where sudden, uncharacteristic behavior erupts as a form of release. Anthropologists have noted that Piblokto is most often observed in traditional Inuit communities, where cultural norms and practices play a central role in shaping how mental distress is expressed. In these settings, the community's understanding of the syndrome helps mitigate its effects. Instead of stigmatizing or punishing those who experience episodes, the community often provides care and support, viewing the behavior as a temporary state that will pass. This cultural context may serve as a protective factor, reducing the long-term impact of the episodes and helping the individual reintegrate smoothly once they recover. While Piblokto is most commonly associated with the Inuit, similar phenomena have been documented in other cold, remote environments, where isolation and environmental stress are significant factors. These parallels suggest that Piblokto may not be entirely unique to Arctic cultures, but rather a reflection of how extreme environmental conditions can shape human behavior and mental health. By examining Piblokto and other culture-bound syndromes, researchers gain valuable insights into the interplay between culture, environment, and psychology. In modern times, reports of Piblokto have become increasingly rare. This decline may be attributed to changing lifestyles, improved nutrition, and greater access to healthcare and mental health resources in Arctic communities. However, historical accounts and early anthropological studies continue to provide a window into how traditional societies understood and managed unique mental health phenomena. Piblokto underscores the importance of viewing mental health through a cultural lens. It reminds us that the way people express psychological distress is often shaped by their environment, social structure, and cultural beliefs. Understanding these factors not only helps us provide more compassionate care, but also deepens our appreciation for the diverse ways in which human beings adapt to and navigate the challenges of their world. Witzelsucht. Witzelsucht, from the German word for joke addiction, is a rare neurological condition that causes individuals to compulsively make inappropriate jokes, puns, or irreverent remarks, often without regard for timing, context, or the reactions of others. While everyone enjoys a good sense of humor, people with Witzelsucht find themselves unable to control their humorous impulses, leading to an unending stream of quips that can be more perplexing than amusing. The condition isn't about a deliberate desire to entertain. Rather, it stems from underlying neurological changes that affect personality, judgment, and emotional expression. The most common cause of Witzelsucht is damage to the brain's frontal lobes, especially the orbitofrontal cortex or ventromedial prefrontal cortex. These areas are responsible for social behavior, impulse control, and understanding social cues. When they are compromised, often as a result of a traumatic brain injury, stroke, tumor, or neurodegenerative disease, an individual may lose the ability to gauge the appropriateness of their humor or to stop themselves from making comments that others might find puzzling or awkward. Instead of making carefully timed jokes, they produce an endless series of puns, rhymes, and nonsensical remarks, often accompanied by an exaggerated sense of amusement. People with Witzelsucht typically don't recognize the inappropriateness of their humor. They may laugh heartily at their own jokes, even if no one else finds them funny. In more severe cases, they may fixate on certain themes or repetitive jokes, returning to the same quip over and over again. This pattern of behavior can create confusion, frustration, and sometimes embarrassment for family members, friends, and caregivers who may not understand that the condition is neurologically driven rather than a personality trait or intentional behavior. Aside from the constant joking, individuals with Witzelsucht may also display other changes in personality or behavior. They may become more socially uninhibited, engaging in impulsive or erratic actions that were uncharacteristic before the brain damage. In some cases, they might lose the ability to interpret facial expressions, tone of voice, or subtle social signals, making it harder for them to navigate complex social situations. These changes are not limited to humor. They reflect a broader disruption in the brain's ability to regulate behavior and interpret social norms. Diagnosing Witzelsucht requires careful neurological and psychological evaluation. Brain imaging, such as MRI or CT scans, may reveal damage to the frontal lobes or other relevant areas. Neuropsychological testing can help assess the extent of the individual's cognitive and emotional changes. While the compulsion to make jokes is the most noticeable symptom, it often occurs alongside other signs of frontal lobe dysfunction, such as disinhibition, poor impulse control, or difficulty planning and organizing tasks. There is no specific cure for Witzelsucht, as the condition is typically a symptom of underlying brain damage. Treatment focuses on managing the underlying cause, such as treating a tumor or stabilizing a neurodegenerative disease, and helping the individual adapt to their new cognitive and behavioral patterns. Behavioral therapy may be used to help the person recognize inappropriate social cues and practice more appropriate responses, though progress can be slow. In some cases, medications that target impulsivity or mood disturbances might help reduce the frequency of inappropriate joking. Witzelsucht offers a unique window into the relationship between humor, personality, and brain function. It reveals how a disruption in the brain's social and emotional regulation systems can manifest in unexpected ways, turning a normally enjoyable aspect of human interaction into something compulsive and uncontrollable. For those living with the condition, understanding its neurological basis is an important step toward finding ways to cope and maintain meaningful relationships despite the challenges it presents. Phantom vibration syndrome. Phantom vibration syndrome is a modern psychological phenomenon where individuals believe they feel their mobile phone vibrating, often in their pocket or against their skin, when in fact no vibration occurred. This sensation is not caused by a malfunction of the phone, but by the brain interpreting normal body sensations as if they were triggered by a vibrating device. While not officially classified as a medical condition, phantom vibration syndrome has become a widely recognized experience in our tech-driven world, offering insight into how deeply smartphones and other devices have become embedded in our daily lives. The hallmark of phantom vibration syndrome is the subjective perception of a phone vibration when no notification or alert has been sent. Some people report this happening occasionally, while others experience it several times a day. It often occurs in situations where the individual is expecting a message or call, or during periods of stress or heightened awareness. The phantom sensation can feel startlingly real, causing the person to check their phone only to find that no alert occurred. Over time, these false alarms can lead to mild frustration or confusion. One theory behind the phenomenon is that our constant reliance on mobile devices has conditioned our brains to associate certain physical cues, such as pressure from clothing, muscle twitches, or subtle shifts in position, with phone vibrations. In other words, the brain has become so attuned to expecting these alerts that it sometimes misinterprets benign sensations as vibrations. This is similar to how people may feel the phantom sensation of a missing limb or misattribute normal bodily signals after losing a regular sensory input. In the case of phantom vibration syndrome, it's not that the device is faulty, but rather that the brain has learned to expect vibrations and occasionally makes a false prediction. Another explanation involves our heightened state of connectivity and the anxiety it can produce. Many individuals have developed an almost reflexive habit of checking their phones, creating a constant anticipation of incoming communication. This heightened alertness can prime the brain to detect vibrations where there are none. The more frequently a person checks their phone, the more likely they are to experience these phantom alerts, as the brain repeatedly rehearses the association between certain sensations and the act of checking the device. While phantom vibration syndrome is not considered harmful, it highlights how modern technology can shape our perception of the world. It serves as a reminder that our brains are highly adaptable, sometimes to a fault, and can easily form new habits and associations when faced with repetitive stimuli. The condition is also a sign of how deeply our devices are integrated into our daily routines. to the point that we can feel their presence even when they aren't signaling us. For those who find these phantom vibrations annoying or disruptive, the best approach is to increase awareness of their technology habits and consider making small adjustments. Simple steps like turning off vibration alerts, keeping the phone in a different pocket, or setting aside regular phone-free times can help reduce the frequency of phantom sensations. Over time, these adjustments may retrain the brain to rely less on constant alerts and more on intentional phone-checking behaviors. Phantom vibration syndrome may not be a serious medical condition, but it sheds light on how technology influences not only our behavior, but also our sensory perceptions. It reminds us that even something as seemingly minor as a phone's vibration can have a profound impact on how we experience our physical world. By paying closer attention to these subtle effects, we can better understand the relationship between technology, the mind, and the body in our increasingly connected lives. COVID syndrome. COVID syndrome, sometimes called sympathetic pregnancy, is a fascinating psychological phenomenon where a male partner of a pregnant woman experiences physical symptoms that mimic those of pregnancy. These symptoms can include nausea, weight gain, abdominal pain, mood swings, backaches, fatigue, and even food cravings. While not a formally recognized medical condition, COVID syndrome has been documented across various cultures and historical periods, making it a curious and often perplexing topic for researchers and expectant couples alike. The onset of COVID syndrome often coincides with certain stages of the partner's pregnancy, such as the first trimester or the weeks leading up to delivery. In some cases, symptoms appear sporadically throughout the pregnancy. The male partner may find himself feeling physically unwell or emotionally unsettled, even though there is no biological cause for these experiences. The term couvade derives from a French word meaning to hatch or to brood, reflecting the idea that the partner is metaphorically incubating his own set of pregnancy-related sensations. The exact cause of couvade syndrome remains a mystery, but several theories have been proposed. One hypothesis is that psychological factors, such as heightened empathy, stress, or anxiety about the upcoming birth, can manifest physically. As the expectant mother's pregnancy progresses, the partner may become more attuned to her experiences and unconsciously internalize some of the changes she is going through. This emotional connection could lead to physical symptoms that mirror her pregnancy, even though there is no direct biological mechanism involved. Another theory suggests that hormonal changes in the partner may play a role. While the evidence is limited, some studies have found that men who experience couvade symptoms show slight increases in certain hormones, such as prolactin and cortisol, during their partner's pregnancy. These hormonal shifts could be related to the stress of impending fatherhood, the physical closeness to the pregnant partner, or other unknown factors. If true, it would suggest that couvade syndrome is not purely psychological, but involves a complex interaction of mind and body. Cultural and social factors may also contribute to the condition. In some traditional societies, rituals associated with pregnancy and childbirth involve the male partner taking on symbolic pregnancy symptoms or roles. In these contexts, couvade-like behaviors are expected and even encouraged, blurring the line between cultural practice and psychological phenomenon. In modern settings, where such rituals are less common, couvade syndrome is often viewed as an unconscious response to the stress and excitement of becoming a parent. Couvade syndrome is not typically considered harmful, and the symptoms usually disappear after the baby is born. However, for some men, the physical discomfort or emotional strain can be distressing. Reassurance from healthcare providers, open communication with the pregnant partner, and stress reduction techniques can all help alleviate symptoms. In most cases, understanding that the condition is temporary and likely driven by psychological factors is enough to put the affected individual's mind at ease. While it remains a puzzling and often overlooked phenomenon, Couvade syndrome underscores the profound emotional and physical interconnectedness that can arise during pregnancy. It highlights how deeply humans are influenced by their relationships and environments, and how the process of welcoming a new life can have far-reaching effects on both parents. For those experiencing Couvade syndrome, it can be a reminder of the strong emotional bond that forms even before the baby is born, and a testament to the shared journey of parenthood. Coro syndrome. Coro syndrome, sometimes referred to as genital retraction syndrome, is a culturally bound condition characterized by the intense belief that one's genitals are retracting into the body. This belief is often accompanied by extreme anxiety, panic, and fear that such retraction will lead to death. While the condition is most famously reported in parts of Southeast Asia, particularly China, Malaysia, and Indonesia, cases have been documented worldwide, demonstrating how cultural and psychological factors can intersect in unexpected ways. For someone experiencing Coro syndrome, the sensation feels very real. They may perceive a physical shrinking or retraction of the penis, or in women, the vulva or nipples, and interpret this change as life-threatening. This leads to severe distress, which often prompts the person to seek immediate intervention, such as pulling on the affected body part or having others hold it to prevent further retraction. In some cases, individuals turn to traditional healers, family members, or even medical professionals, convinced that swift action is needed to avert catastrophe. Coro is more than just a physical concern. It's deeply rooted in cultural beliefs and societal anxieties. In many of the regions where it is most prevalent, the condition is associated with traditional views of health, masculinity, fertility, and spiritual balance. For example, some cultures attribute Coro to yin-yang imbalances, curses, or supernatural forces. These cultural frameworks shape how individuals interpret their bodily sensations and fears, turning a momentary feeling of discomfort into a full-blown crisis. While the syndrome often occurs as an isolated case in an individual, there have also been Coro epidemics, or outbreaks reported throughout history. These episodes typically follow rumors of a spreading illness or supernatural punishment, causing large groups of people to report similar symptoms. The power of suggestion and social influence plays a significant role in these outbreaks, illustrating how fear and belief can propagate rapidly within close-knit communities. From a psychological standpoint, Coro is often classified as a form of somatic delusion or panic disorder. The condition tends to arise during times of stress, anxiety, or uncertainty, suggesting that underlying emotional distress is a contributing factor. Neurological or psychiatric conditions, such as schizophrenia, depression, or certain anxiety disorders, can also predispose individuals to developing Coro. In these cases, the person's mental state amplifies their bodily perceptions, turning ordinary sensations into sources of fear. Treatment for Coro focuses on reassurance, education, and addressing any underlying mental health issues. For those without a coexisting psychiatric disorder, simple reassurance from a trusted health professional can often alleviate the fear. Explaining the natural variability in body sensations, combined with a calm and supportive approach, can help the individual recognize that their genitals are not actually retracting and that their life is not in danger. For those with co-occurring conditions, psychotherapy, cognitive behavioral therapy, CBT, or medication may be necessary to manage anxiety, delusions, or panic symptoms. Coro syndrome offers a fascinating glimpse into the ways that culture and psychology intertwine to shape our experiences of the body. It highlights how deeply held cultural beliefs can influence the interpretation of physical sensations, and how fear and suggestion can spread through communities. While Coro is deeply distressing for those who experience it, it also serves as a powerful reminder of the complexity of the mind-body connection and the importance of cultural sensitivity and understanding in mental health care. Jumping Frenchman of Maine. The jumping Frenchman of Maine refers to a rare neurological condition observed in the late 19th century among a small group of French-Canadian lumberjacks working in the forests of northern Maine. These individuals exhibited an exaggerated startle reflex, responding to sudden noises or unexpected movements with uncontrollable, almost reflexive actions. For instance, if someone shouted or startled them, they might leap into the air, shout, mimic the actions or words of others, or even carry out commands immediately, without any apparent ability to stop themselves. The behavior was first formally described in 1880 by Dr. George Miller Beard, who was struck by how dramatically these lumberjacks responded to minor stimuli. Beard's observations included individuals who would drop their tools, perform backflips, repeat phrases, or act out instructions given in the heat of their startle response. This exaggerated startle reaction was so severe that it resembled a neurological or psychiatric condition rather than a simple heightened sensitivity to surprises. The exact cause of the jumping Frenchman phenomenon remains unknown, but there are several theories. Some researchers have suggested that the condition might be a form of hereditary startle disorder, linked to an overactive brainstem reflex. Others have pointed out that the isolated environment of the lumber camps and the close-knit nature of the French-Canadian community may have played a role. This theory proposes that cultural or social factors, such as mimicry, stress, or peer influence, could have contributed to the perpetuation and reinforcement of these behaviors within the group. The fact that this exaggerated startle reflex was largely confined to a small, specific population further underscores the potential influence of shared genetics, environment, or cultural practices. Although the term jumping Frenchman of Maine is often associated with a historical group, similar startle syndromes have been reported in other parts of the world. For example, a condition called lata, observed in Malaysia and Indonesia, also involves an extreme startle response followed by automatic, uncontrollable actions or speech. Another example is miriachit, reported in Siberia. The similarities between these conditions suggest that there may be a common neurological basis, even if cultural differences influence how the syndrome manifests and how it is interpreted by those who experience it and those who observe it. In modern times, the jumping Frenchman phenomenon is no longer widely reported, and its prevalence appears to have declined significantly. Whether this is due to changing social structures, different environmental conditions, or simply a lack of contemporary documentation is unclear. Some scientists have speculated that as the lumberjack camps dispersed and the tight-knit community dissolved, the behaviors may have diminished or disappeared. However, the historical accounts continue to fascinate neurologists, anthropologists, and psychologists who see in the phenomenon a unique interplay of genetics, environment, and culture. For the individuals who were affected, life could be challenging. The inability to control their responses made them highly susceptible to embarrassment, accidents, and difficulties in their day-to-day work. Yet within their community, the condition was often met with a mix of curiosity and understanding rather than outright ridicule. This environment of acceptance may have helped those affected cope with their unusual reflexes, even if no formal treatment was available. While there are no specific treatments or interventions associated with the jumping Frenchman of Maine phenomenon, its legacy lies in what it reveals about human neurological diversity and the ways in which cultural context shapes our understanding of medical conditions. It stands as a reminder that the mind and body's reactions to the world around us can vary widely, sometimes creating extraordinary behaviors that challenge conventional explanations. Boanthropy. Boanthropy is an exceedingly rare psychological condition in which a person comes to believe that they are a cow or an ox. This delusion typically results in behavior that mimics that of cattle, walking on all fours, grazing on grass, or displaying other bovine-like actions. While often regarded as a historical curiosity, boanthropy is mentioned in both ancient texts and more modern psychological literature as a striking example of how the mind can create deep, animalistic identifications. The most well-known reference to boanthropy appears in the Book of Daniel in the Bible, where King Nebuchadnezzar is said to have been driven from his palace to live like an animal. According to the account, he grazed on grass and behaved like an ox until he eventually regained his senses. While it's impossible to confirm the historical accuracy of this story, it has long been cited as one of the earliest descriptions of boanthropy and has inspired both religious and psychological interpretations. Some have argued that it reflects divine punishment or moral lessons, while others see it as an early observation of a profound psychological disturbance. In more recent times, boanthropy has occasionally been documented by psychiatrists and psychologists. Those who experience the condition often describe a shift in their identity that feels deeply real to them. They may reject human food, attempt to spend time outdoors in fields, or even physically position themselves as if they were livestock. These behaviors are not simply eccentric or attention-seeking, they reflect a genuine conviction that the individual has become a bovine animal. The causes of boanthropy are not well understood, largely because the condition is so rare. However, many researchers believe it is related to other forms of delusional thinking. It might stem from a psychotic disorder, such as schizophrenia, or develop as a result of severe trauma or emotional stress. The delusion could also arise in a context of cultural or religious beliefs that place symbolic significance on certain animals, leading a person to identify with or embody those traits. Neurologically, boanthropy might involve disruptions in the brain regions responsible for self-awareness and identity. The prefrontal cortex, which helps maintain our sense of self and personal agency, may be compromised or altered, causing the individual to lose the normal boundaries between human and animal identity. In some cases, certain forms of epilepsy, brain injuries, or neurodegenerative conditions have been implicated in creating vivid, unusual beliefs that affect how a person perceives their own body and mind. Because boanthropy is so rare, treatment options are typically tailored to the individual's underlying condition. If the delusion is part of a broader psychotic disorder, antipsychotic medications may help. Psychotherapy, particularly cognitive behavioral approaches, can assist the person in challenging their belief system and gradually restoring a more stable sense of identity. Support from family and friends is also crucial, as those affected may feel isolated or misunderstood. A compassionate approach, combined with careful psychiatric care, often offers the best path forward. Boanthropy captures the imagination not only because of its rarity, but also because it invites questions about the boundaries of human identity. How flexible is our sense of self? What triggers a shift from one identity to another, even to that of another species? These questions have fascinated religious thinkers, anthropologists, neurologists, and psychologists for centuries. Although modern cases are exceedingly uncommon, boanthropy serves as a reminder of the mind's profound capacity for transformation and the complex ways in which psychological, neurological, and cultural factors can shape our perception of who we are. Hyperthymesia. Hyperthymesia, also known as highly superior autobiographical memory, HSAM, is a condition in which individuals can recall an extraordinary number of life experiences with incredible accuracy and detail. People with hyperthymesia are able to remember events from their past as vividly as if they happened yesterday, often describing specific dates, conversations, and emotions without the need to rely on notes, photos, or other external reminders. This rare and remarkable ability sets them apart from the vast majority of people, for whom memory is more selective, imprecise, and subject to decay over time. What makes hyperthymesia unique is that it isn't a skill that can be taught or trained. It's a spontaneous ability. Those with HSAM don't have photographic memory. Rather, their memory is autobiographical, meaning it's focused on their own personal experiences rather than random facts or images. For example, they might recall exactly what they were doing, wearing, and feeling on a specific date years earlier. This ability typically becomes evident in late childhood or adolescence, and once it emerges, it remains consistent throughout the person's life. The exact cause of hyperthymesia is not yet fully understood, but researchers believe that it may involve unique differences in how the brain organizes and stores memories. Studies of individuals with HSAM have revealed structural differences in certain areas of the brain, such as the caudate nucleus and the temporal lobe. These regions are associated with memory processing, emotional regulation, and habit formation, suggesting that hyperthymesia may result from an unusually robust network of connections that allows memories to be both deeply encoded and easily retrieved. Interestingly, having hyperthymesia is not necessarily all positive. While it can be fascinating and even advantageous to remember past experiences with such clarity, it can also be overwhelming. Some people with HSAM report feeling burdened by their constant recall, particularly when the memories are emotionally painful or distressing. Instead of fading over time, these memories remain as vivid as the day they occurred, making it difficult to move on from negative experiences. As a result, individuals with hyperthymesia may be more prone to ruminating on past events or feeling stuck in certain emotional states. Because hyperthymesia is not considered a disorder or an illness, there is no specific treatment or intervention. However, individuals with HSAM may benefit from learning techniques to manage emotional memories, such as mindfulness, stress reduction practices, or counseling to help process and cope with difficult recollections. These approaches can help them strike a balance between appreciating their unique gift and navigating the emotional challenges that come with it. Hyperthymesia is an exceptional reminder of the diversity of human memory. It highlights how memory is not just a singular faculty, but a highly complex and variable process influenced by biology, emotion, and individual differences. For those who possess this rare ability, it offers a unique lens on life, one in which every moment, both joyful and painful, remains vividly within reach. Pathological demand avoidance, PDA, is a behavior profile within the autism spectrum that is characterized by an extreme resistance to everyday demands and expectations, coupled with a need to assert control over one's environment. First described in the 1980s by developmental psychologist Elizabeth Newson, PDA has become a topic of growing interest and debate in the field of autism research. Although not officially recognized as a distinct diagnosis in major diagnostic manuals, PDA is widely acknowledged as a distinct set of traits and behaviors that can significantly impact an individual's life and relationships. The defining feature of PDA is the overwhelming drive to avoid or resist demands. These demands can range from direct instructions, such as get dressed or finish your homework, to more subtle social expectations, such as maintaining eye contact or participating in a conversation. People with PDA often feel an intense, almost instinctive need to say no, delay compliance, or divert attention away from the request. This resistance is not simply oppositional or defiant. It's rooted in a deep-seated anxiety and a need to maintain autonomy and control. In many cases, individuals with PDA exhibit highly social behaviors that can initially mask their challenges. They may appear charming, articulate, or socially engaged, yet this outward sociability often belies their internal struggle with demands. Unlike other profiles on the autism spectrum, where social communication difficulties are more pronounced, those with PDA may use their social skills as a strategy to deflect demands, distract others, or shift the focus of a situation. This can make it harder for caregivers, educators, and clinicians to recognize and understand the underlying nature of the behavior. The strategies people with PDA use to avoid demands can vary widely. They might refuse outright, make excuses, distract by talking excessively, change the subject, or engage in what appears to be deliberate non-compliance. When demands are pushed, or when they feel their autonomy is being threatened, they may experience intense anxiety, meltdowns, or even aggressive outbursts. In such moments, the person's need to escape the situation overrides their ability to process or respond rationally. The root causes of PDA are not fully understood, but it is generally considered to be a profile within the autism spectrum, rather than a separate condition. Researchers believe that the avoidance behaviors are closely linked to heightened anxiety, a strong need for control, and a hypersensitivity to perceived pressure. Neurological differences in processing social and environmental cues likely play a role, as does the unique way individuals with PDA experience and regulate their emotions. Because PDA is not officially recognized in diagnostic manuals like the DSM or ICD, diagnosing it can be challenging. Professionals often rely on careful observation, detailed behavioral histories, and input from parents, caregivers, and teachers. The term PDA is more commonly used in the UK than in other parts of the world, where clinicians may simply describe the behavioral profile without using the specific label. Nevertheless, awareness of PDA is growing, and many families and practitioners find the concept helpful in understanding and supporting affected individuals. Approaches to supporting individuals with PDA typically involve reducing demands, creating flexible and low-pressure environments, and emphasizing collaboration rather than confrontation. Traditional behavioral approaches that rely on strict routines or reward-based compliance can backfire, as they may increase anxiety and resistance. Instead, strategies that build trust, respect the individual's need for control, and incorporate their interests and preferences are often more effective. For example, offering choices, breaking tasks into smaller steps, and using humor or creativity can help reduce the perceived pressure of demands. PDA underscores the complexity of the autism spectrum and the diversity of experiences within it. It challenges us to rethink traditional approaches to parenting, teaching, and therapy by placing a greater emphasis on understanding the underlying motivations and anxieties driving behavior. By adopting more flexible, empathetic strategies, we can help individuals with PDA navigate a world full of demands without feeling overwhelmed or threatened. Dissociative Identity Disorder, DID, Dissociative Identity Disorder, DID, formerly known as multiple personality disorder, is a complex and often misunderstood mental health condition in which a person experiences the presence of two or more distinct identity states, or alters. These alters may have their own names, characteristics, voices, and ways of interacting with the world. For those living with DID, these identity states alternately take control of their behavior, thoughts, and feelings. While it is sometimes sensationalized in popular media, DID is a genuine and challenging condition rooted in deep psychological trauma and dissociation. At its core, DID is thought to be a response to extreme stress or trauma, often experienced during early childhood. When a child is repeatedly subjected to overwhelming abuse or neglect, their developing mind may split as a coping mechanism. Instead of processing the trauma as a single, cohesive identity, the mind creates separate identity states to manage the emotional burden. These alters serve to compartmentalize painful memories and emotions, shielding the person's primary identity from the full impact of their experiences. Over time, these identity states become more distinct and may emerge in response to specific triggers or situations. People with DID often report memory gaps, periods of time they cannot account for, or feeling as though they lose time. This occurs because when one alter is in control, the others may not be aware of what is happening. For example, a person might find themselves in a location they don't remember going to, see objects they don't recall buying, or discover they've said or done things that feel foreign to them. These memory disruptions are a hallmark of the disorder and reflect the dissociative nature of the condition. The alters within a DID system can vary widely. Some may be childlike, others more protective, and still others may carry specific memories or emotions associated with past trauma. Alters can also differ in gender, age, accents, or even physical mannerisms. Importantly, these states are not acting or deliberate role-playing. They represent distinct ways the brain has organized itself to cope with overwhelming experiences. For the person living with DID, these alters feel real and autonomous, often interacting internally with each other in ways that can resemble conversations or arguments. DID is often accompanied by other mental health challenges, such as depression, anxiety, post-traumatic stress disorder, PTSD, and substance use disorders. These co-occurring conditions can make the experience even more overwhelming. Additionally, many people with DID face skepticism or misunderstanding from others, leading to feelings of isolation or shame. This stigma can make it difficult for them to seek help or explain their condition to friends, family, or employers. The diagnosis of DID requires a thorough psychological evaluation conducted by a mental health professional who is experienced in dissociative disorders. The clinician will assess the person's symptoms, history of trauma, patterns of dissociation, and the presence of distinct identity states. Since DID can be mistaken for other conditions, such as borderline personality disorder or schizophrenia, careful differential diagnosis is essential. When properly identified, DID can be addressed through specialized therapeutic approaches. Treatment for DID typically involves psychotherapy aimed at integrating the various identity states and addressing the underlying trauma that led to the dissociation. The goal is not necessarily to eliminate the alters, but to help the person achieve greater internal communication and cooperation between them. Over time, therapy can help the individual develop a more unified sense of self and reduce the disruption caused by memory gaps or identity shifts. Techniques such as trauma-focused therapy, cognitive behavioral therapy, CBT, and mindfulness can be beneficial, along with creating a safe and stable therapeutic environment. Dissociative identity disorder highlights the incredible complexity of the human mind and its ability to adapt in the face of unbearable circumstances. For those living with DID, the journey toward healing often involves reclaiming lost parts of themselves and learning to live as a more cohesive whole. While the path can be difficult, understanding, compassion, and specialized care can make it possible for individuals with DID to lead fulfilling, stable, and meaningful lives. Depersonalization, derealization. Disorder is a dissociative condition marked by persistent feelings of being detached from oneself or disconnected from the surrounding environment. People experiencing depersonalization often report feeling like an observer of their own actions, as though they are watching themselves from a distance or moving through life in a dreamlike state. Derealization, on the other hand, is characterized by a sense that the world around them is not real. Objects may seem distorted, people may appear as if they're behind a glass pane, or the environment may feel unusually flat or lifeless. These experiences can be profoundly unsettling, leaving individuals questioning their reality and identity. What sets DPDR apart from transient feelings of detachment, such as zoning out or daydreaming, is its persistence and intensity. The sensations don't simply pass after a moment. They can last for hours, days, or even longer, significantly interfering with daily life. The person knows their experiences are not hallucinations, and they maintain an awareness that something feels off, rather than truly believing that the world or their body has changed. This insight distinguishes DPDR from psychosis and underscores the condition's unique position within the spectrum of dissociative disorders. DPDR is often linked to high levels of stress, trauma, or anxiety. Many individuals report that symptoms began during periods of intense emotional distress, such as a major life event, the death of a loved one, or an episode of panic. For some, DPDR may be a response to prolonged stress, while others experience it as a result of acute trauma or after a particularly frightening experience. In these moments, the mind may use dissociation as a coping mechanism, creating a buffer between the individual and their overwhelming emotions. Over time, however, this protective mechanism can become chronic, leaving the person feeling persistently detached even after the initial stressor has passed. Diagnosing DPDR typically involves a comprehensive assessment by a mental health professional. The clinician will explore the individual's symptoms, history of trauma or stress, and any co-occurring mental health conditions. It's important to rule out other potential causes of the symptoms, such as substance use, medical conditions, or other psychiatric disorders. Once diagnosed, treatment can begin, often focusing on both the underlying triggers and the dissociative symptoms themselves. Therapy is the cornerstone of treatment for DPDR. Cognitive behavioral therapy, CBT, can help individuals challenge distorted thinking patterns, address underlying anxiety, and develop grounding techniques to reconnect with the present moment. Mindfulness and meditation practices are also commonly recommended, as they encourage a non-judgmental awareness of sensations and thoughts, helping individuals feel more rooted in their bodies and surroundings. For those whose DPDR is linked to trauma, trauma-focused therapies, including EMDR, eye movement desensitization, and reprocessing, can help process and integrate distressing memories, potentially reducing dissociative symptoms. Depersonalization, derealization disorder serves as a reminder of how profoundly stress and trauma can impact perception and the sense of self. For those who experience it, DPDR can feel deeply isolating, but with the right support and treatment, many individuals find ways to reconnect with their world and themselves, regaining a sense of reality and wholeness. Dissociative fugue. Dissociative fugue is a rare dissociative disorder characterized by sudden, unexpected travel away from one's home or usual place of daily activities, accompanied by a loss of memory for personal identity and past events. During a fugue state, individuals may appear to function normally and carry out routine tasks, but they often cannot recall who they are, where they came from, or any details of their past life. In some cases, they may even assume a new identity and live under this new persona for a period of time, ranging from hours to months. Once the fugue state ends, the person typically regains their original memories, but often has little to no recollection of what occurred during the fugue. Dissociative fugue often occurs in response to severe stress or trauma. For instance, individuals might enter a fugue state after experiencing a deeply distressing life event, such as the death of a loved one, a natural disaster, or personal violence. The fugue state can be understood as the mind's way of coping with overwhelming emotions by essentially shutting off access to painful memories and creating a psychological distance from the source of distress. This dissociation allows the individual to function in the short term, but it results in significant gaps in memory and a disruption of personal identity. Unlike other forms of dissociation, where individuals may feel disconnected from their thoughts, feelings, or environment, dissociative fugue involves a complete break from one's established sense of self. It's as though the individual temporarily starts over with no conscious awareness of their previous life. This can lead to behaviors that seem out of character to those who know them, such as taking on a different job, adopting new habits, or moving to a completely unfamiliar place. Family and friends may be left confused and alarmed, wondering how and why their loved one disappeared without warning or explanation. When the fugue state resolves, the individual typically experiences a sudden return of their previous identity and memories. This can be a disorienting and emotionally challenging moment as they try to piece together what happened and reconcile their past with their present. For many, the period of the fugue feels like a blank in their memory, though some may recall fragments of experiences without a coherent narrative. Because dissociative fugue is rare and its symptoms can resemble other conditions, it often requires careful evaluation by a mental health professional. Diagnosing fugue involves ruling out medical causes of memory loss, such as neurological conditions, substance use, or head injury. Once these possibilities are excluded, the clinician will explore the individual's psychological history, patterns of dissociation, and any recent stressors or traumas that could have triggered the fugue. Treatment for dissociative fugue usually focuses on addressing the underlying psychological issues that contributed to the dissociation. This may involve psychotherapy, particularly trauma-focused approaches, or cognitive behavioral therapy, CBT, to help the individual process distressing memories and develop healthier coping mechanisms. Supportive therapy can also help them navigate the emotional impact of losing time, rebuilding relationships, and understanding the cause of their fugue state. In addition to therapy, stress reduction techniques such as mindfulness, relaxation exercises, and lifestyle changes can help prevent future episodes. Building a strong support system, including trusted friends, family, and mental health professionals, is crucial for fostering a sense of stability and reducing the likelihood of another fugue. While there's no specific medication to treat dissociative fugue, addressing co-occurring conditions like anxiety or depression through medications and therapy may help. Dissociative fugue is a vivid example of how the mind can react to overwhelming circumstances by temporarily stepping away from the self. It highlights the extraordinary ways that human consciousness can adapt, and the challenges that arise when these adaptive mechanisms become disruptive. For those who experience it, recovering from dissociative fugue involves not only regaining a sense of identity, but also learning to face life's difficulties with resilience and support. Pica. Pica is a psychological condition characterized by the persistent craving and consumption of non-food substances. These can include items such as dirt, clay, chalk, paper, soap, hair, ice, paint chips, or even small objects like coins. While many children occasionally put non-food items in their mouths, pica involves an ongoing compulsive desire to consume these materials over a period of at least 1 month, often despite their potentially harmful effects. The condition is most commonly observed in children, pregnant individuals, and people with certain developmental disorders, though it can occur at any age and among individuals from all backgrounds. The causes of pica are complex and not fully understood, but several factors appear to contribute to its development. Nutritional deficiencies, particularly in iron or zinc, are thought to play a significant role in triggering cravings for non-food substances. In some cases, the body's attempt to correct these deficiencies may lead to unusual cravings. For example, a person with iron deficiency anemia might crave soil or clay, as these substances may contain trace minerals that the body associates with the missing nutrient. Beyond nutritional factors, pica can also be linked to developmental and behavioral conditions. Individuals with intellectual disabilities, autism spectrum disorder, or certain psychiatric disorders may be more likely to engage in pica behaviors. For these individuals, consuming non-food items may provide sensory stimulation, comfort, or a way to self-regulate emotions. Similarly, in pregnant individuals, hormonal changes and heightened nutritional needs can lead to cravings for non-food substances, though these cravings typically resolve after childbirth. Cultural and environmental factors may also play a role in the prevalence of pica. In some cultures, the consumption of certain non-food items, such as clay or charcoal, may be a traditional practice or a culturally accepted remedy for specific health conditions. While these behaviors may not always be viewed as pathological within their cultural context, they can still pose health risks if consumed in excess or if the substances contain harmful contaminants. The potential dangers of pica depend on the specific substances consumed and the amount ingested. Some non-food items may cause physical harm by obstructing the digestive tract, damaging teeth, or introducing toxins into the body. Others, such as soil or unclean objects, may expose the individual to infections, parasites, or harmful bacteria. In extreme cases, the ingestion of certain substances, such as lead-based paint chips, can lead to poisoning, cognitive impairment, and long-term health problems. Diagnosing pica involves a thorough assessment by a healthcare professional. The diagnosis is based on a pattern of non-food consumption that persists over time and cannot be attributed to a developmental stage or cultural practice alone. The healthcare provider may also conduct medical tests to identify any underlying nutritional deficiencies, gastrointestinal issues, or other conditions that could be contributing to the behavior. Treatment for pica focuses on addressing the underlying causes and reducing the associated health risks. If a nutritional deficiency is identified, supplementation of the missing nutrients, such as iron or zinc, often helps diminish the cravings. Behavioral therapy can be highly effective, particularly for individuals with developmental or psychiatric conditions. Cognitive behavioral techniques, positive reinforcement, and environmental modifications can help reduce the frequency of pica behaviors. In some cases, medication may be prescribed to manage underlying mental health issues or to curb obsessive-compulsive tendencies. Pica is a reminder of how complex and varied human appetites can be, reflecting both biological needs and psychological factors. It illustrates the importance of a holistic approach to health, considering not just physical symptoms, but also emotional, cultural, and environmental influences. With proper treatment and support, individuals with pica can reduce their cravings, address any associated health issues, and achieve a better quality of life.